talk being presented to you by IBMCC independent volunteers monitoring COVID care. So now you know what IBMCC means. My name is Teta and I will be your moderator for the night. Before we begin, we just want to lay down some rules so that we can have a nice and focused session. Next slide, please. Let's just have some Zoom etiquette here. Please mute all your microphones. And then if you do have questions, just type it in the chat box and our volunteers will filter it later so that we don't have double questions, we don't keep repeating things, and we don't waste each other's time. Okay? Do not distract other participants. If you want to open your cam, it's okay. But if you're going to open your cam, please make sure that there's not much people walking around or you have pets with you, nothing to distract anyone so that we can be focused. And of course, if you will be able to be given the chance to talk later, please speak clearly. All right. So now let's bow our heads together in prayer. Isai?
Yes. Dear Father, we are in the midst of a battle against the virus that has weakened so many of our brothers and sisters. Look at us with kind eyes and warm our hearts with your spirit of hope. Open our minds to learn as much and as quickly as we can so that our virtual hands may become instruments to heal. Clear our hearts of ego and pride so that we may wholeheartedly share our blessings to care for every person who seeks our help. Make us always aware that whatever we do comes from the beauty of your grace and love. This we ask through Jesus Christ our Lord. Amen.
So to introduce to you our organization, IBMCC, let's all welcome our core team member founder, G. Bernardo.
Oh, good evening, everyone. So as Teta mentioned earlier, we are IBMCC, independent volunteers monitoring COVID care. We are independent, meaning we are non-denominational and we have no political affiliation. We assist COVID patients who prefer to do home care. We link them to doctors and monitor them according to the doctor's prescription and instructions. All monitoring done is free. None of us have any medical background except for one registered nurse who is from Oriental Mindoro. We have volunteers from varying ages and a senior as 71 years old, and he's from Iloilo. All of the monitoring is done virtually through FB Messenger. We began last April, and it was just like what I mentioned to Dr. Villa. It wasn't planned at all, but it was formed out of need. From 4 volunteers back in June, we're now about 50 plus with 24 active volunteers at present. We have 4 main teams focused on patient care who are currently monitoring about 50 patients. From having a single doctor with no direct thread when we started, we now have 11 doctors holding virtual clinics with IBMCC, and we thank each one of them. We thank the Lord for forming this group and orchestrating events which led us where we are now. We're blessed to have Dr. Homer Lim for his invaluable support since the beginning and for leading us to CDCPH and to more doctors and for always providing guidance. By God's grace, we've monitored and have witnessed the recovery of about 300 patients. And as long as there are patients needing help, we will be here to provide support in any way we can as the Lord leads. Thank you.
Okay, thank you very much, G. Okay, now I'd like to introduce to you our speaker. Our speaker for tonight is a native of the Philippines, but she brings many of her traditional ethnic holistic protocols to her patients in the US to include the 3 spheres of health: physical, emotional or mental, and spiritual. She graduated from the University of the East College of Medicine here in Manila, completed her clinical apprenticeship at Southampton University and St. Mary's Medical Center at Portsmouth, England. She completed internship and residency at Albert Einstein and Seton Hall Universities and her fellowship at Tulane University. She is a former associate professor at the University of Central Florida College of Medicine, was ICU director at the Villages Regional Hospital, a former medical director of the TVRH Pulmonary Rehab Center, Tri-County Physician Sleep Center, and Tri-County Pulmonary and multi-specialty group. She is a practicing internist with subspecialties in pulmonary, sleep and critical care medicine, functional medicine, anti-aging medicine, and is a certified provider for bioidentical hormone replacement and nutrition therapy. She is affiliated with the Villages Medical Center and Leesburg Regional Medical Center. She is a very active member of the Concerned Doctors and Citizens of the Philippines, or what we call CDCPH, and an associate provider of the Frontline COVID-19 Critical Care Alliance, or FLCCC. Let us all welcome Dr. Marivic Villa. Thank you very much, Doc, for coming over.
Okay, I'm on. Hello, everyone, and good evening. It's a pleasure to be here, and I hope that we all can learn, even me, from what I'm going to talk about. And it is every time I give a talk to any group, I always make sure and always start with explaining actually the disease process, because I always emphasize this. For any disease, it is very easy to intervene and apply the right medication or appropriate agents if you know what's going on or what the disease process is all about. Okay, so my I have quite a few slides to present to you, but we're gonna go through that quickly, as fast as I can, so that we can entertain question if there are questions. I'd like to have what do you call this, direct communication with all the docs, because the doctors are what you need to cooperate with you so that we can help more people. We only have 24 hours a day, so one person is not going to be as strong as 3, 4, 5, 6, and if we have 10 or 11, that's even better, because this disease, it doesn't have a silver bullet. Okay, and this disease doesn't discriminate. It will infect anybody and anyone, except that some are more susceptible and some are more at risk. Okay, so the first slide, it says, so we're gonna try and understand the pathophysiology, and the pathophysiology and the disease process. That's where you get the basis and the clinical rationale for using what agent at what particular stage of the disease. Now, with our experience for almost 2 years now, we've already concluded, and I am very strong on this, that prophylaxis and early treatment are the best way to do it, for us to make a difference, in saving lives. But obviously, not everybody has access to whatever it is that we are wanting to give to the people for prophylaxis and early treatment. So we are forced to treat people even in their moderate and even severe, cases. I've helped so many people in the Philippines to manage those kind of cases, and obviously I manage those kind of cases here in America. And people, for one reason or another, they actually don't want to get hospitalized, and you cannot blame them. Why? Because number one, they have this general idea that if they go into the hospital, they're not coming out anymore. And number two, for those people who are actually well informed, because they do research, they ask around and research on their own, for their own information and education, they know that the current protocol that we use in the hospital is actually very flawed, and I will tell you why later. Okay, so let's understand first what the disease is all about, and then from there, probably you can formulate the right question or whatever question you have in mind. And so let's continue. And the next slide, please. Do I have the do I have the ability to, move the slides, or you guys are the one moving it?
I'm the one who are going to move.
Okay, all right. Okay, so we know now that the disease actually has two major stages. At least this is what we know as of today. After 2 years of dealing with this pandemic or this disease, we already know that there are two stages. Very simple. Stage one, stage two. The viral phase, the viral stage is stage one, and stage two is the immune stage. I always emphasize this, that the viral stage does not kill you. It is in the immune stage wherein we see people dying. Okay. So the disease also goes through phases, and I put 5 phases. In some literature or some references, you're not going to see phase 5, but I put it there because I manage a lot. I've been through the entire phases of the disease and all the cases that I've been seeing for the last almost 2 years. No, so the 5 phases, you have phase 1, 2, 3, 4, and 5. The phase 1 is the incubation period. The phase 2 symptomatic period, which is the mild, very mild phase, very mild symptom. And then you go into the early pulmonary phase, wherein usually the symptoms are more pronounced, and that's where the patient starts going into trouble. And then it goes in the late pulmonary phase, and this late pulmonary phase is the big trouble, because that's where you see a lot of people, die. And then if you survive these 4 phases, you go, not everybody goes into this. This is what we call long hauler. They have prolonged systemic, prolonged systemic symptoms. And they're like, it's like almost the same symptom as the acute, but it's in a low grade kind of form or level. Okay, so usually once they get into at least 3 months or even 8 to 12 weeks of symptom not resolving, you are considered to be a long hauler. And then that's obviously another ball game. Okay, next slide, please. Okay, so the acute COVID, I also classified it into like different severities, the asymptomatic or pre-symptomatic stage, which is basically the incubation phase. That's phase 1, mild severity, which is the phase 2, the moderate severity, phase 3, severe and critical, critical phase, phase 4, and then you have the prolonged symptom, which is the phase 5. And then finally, if you completely recover, then you go into the recovered phase. Next slide, please. So you have, I'm going to put this in one slide. And then I know this slide is very busy, but I want to put together the entire thing here. Okay. So as you can see, yeah, you have to look at this, the incubation period. You have the incubation phase or incubation period, which is the asymptomatic phase. What's very peculiar about this phase is you have a very high viral replication, and then this is very contagious. This is where people, they are running around without symptom, and then they are infecting other people. It could be 3 to 4 up to 5 days at most. I have patients like that. In the beginning, I actually got it exposed and I thought I got infected, but luckily I wasn't. But a couple of my assistants were infected. She was a police woman and she was completely asymptomatic. 3 days later, she was sick like a dog. Okay. And then so the next phase is the symptomatic phase. This is where the patient get some sign and symptom. You will notice it. They're mild fever, a little bit of cough, sore throat, headache. This is where you lose your smell and taste. You can also have diarrhea if it includes gastrointestinal symptom. If you take an X-ray, you will probably see it could be normal, or you can have mild, we call mild infiltrate. And then in this state as well, one thing is it is a very contagious phase as well. You know, the patient is what do you call this? The patient is coughing, and these are the patient that you really want to completely isolate or quarantine and not, you know, interact with people, because every time they cough or they talk, they could be spewing the virus. Okay, and so the this is also the time that your so-called innate immunity or innate immune system is going to start, you know, waking up. You know, this the first line of defense of your immune system, and this includes like a lot of the cell like macrophages, monocyte, and then they convert into like T cell and B cell and stuff like that. So this innate immunity in young people is very strong. That's why they kill the virus very, very quickly, and they only have a short duration of the disease in young people. In babies, it's even shorter, 2 to 3 days. They get cranky, and then the infection is gone. Now, as it progresses, it goes into the early pulmonary phase. This one, I think, is the opportunity that you can intervene if you are not able to recognize the patient in stage 1. But for sure, in the mild severity or mild cases, you should be able to intervene right away already. Now here, in the early pulmonary phase, this is where you have to make a decision to be very aggressive so that you prevent the patient from getting hospitalized. This is already the phase wherein the symptoms, the sign and symptoms are more pronounced. The patient is going to cough more, or if you do a chest x-ray, you are already going to see it. Even if you don't have experience in looking at chest x-ray, you're going to see infiltrates. One thing here is this is also the phase that the viral replication is already significantly down, because viruses, they are self-limiting disease, right? Infection, they go into a natural decay. So by the time it goes into the early pulmonary phase, the viral replication is already down. Okay, it's coming down, and then your innate immunity is starting to kick in. So by this time, it's already minimal viral replication. The patient could still be infectious, but it's not as bad. And in this state, that's where you, if you do a viral culture, possibly you can do it. But after the 10th day, this is we're talking about, after the 12th day, chances are you won't be able to get a positive viral culture. Okay. One thing that is very, we have to remember is this is where the oxygen is going to start falling. Okay, and that's why it is more important for you to have the pulse ox, the pulse oximetry, that little device that you put on the finger, so that you can look at or you can monitor the oxygen level. I always emphasize this. A normal person without lung disease, like somebody like most of you, you don't have emphysema, you don't have COPD, or you have both lungs present and you don't have anything wrong with you pulmonary wise, your oxygen level should not be down to 94. It should always be 96 and above, especially if you take, you know, a few deep breaths. That should even go up to 99 or 100% on room air. So when the oxygen start dropping down to 94 or below, then the trouble starts. Okay, this is what you are going to monitor, and this is where you're going to intervene. If you need to introduce another medication, like mostly this is where I introduce the corticosteroid. You know, when I use other agent, antiviral agent, that once the oxygen level starts going down, then that's the time you add that corticosteroid. One thing you do not add the steroid very early because it can promote more viral replication. And so the timing is very important. This is really the one that will tell you, let's give steroid already because there are more inflammation, okay? So in this, you chances are, if the oxygen level continues to drop, then you will have to start giving the patient oxygen. This is also where you have to decide if you want to take your relative or whatever part, your family, to the hospital. This is where it starts. And then to be subjected to the protocol in the hospital, that's a decision you have to make. But for the most part, we decide to take our loved ones to the hospital because the oxygen is dropping very low. Now, this is also the phase wherein people are very, very comfortable. This is what we call happy hypoxemic, okay? They are very comfortable, but their oxygen is significantly low. And that is also dangerous because even if you are healthy or normal, then you can only, certain organ system in the body can only withstand very low oxygen for a certain or for a certain period of time. Like, let's say the heart, if you have very low oxygen, even if you are not diseased with your heart, it's going to stop without oxygen, okay? Because it has a very high oxygen requirement. You have the oxygen very low and you have your heart, it needs oxygen to keep on pumping, and then your oxygen level is very low. It's going to stop. It's just like in babies, they go into heart, I mean, respiratory arrest because of the very low oxygen, because the babies, they don't have, I mean, they're very healthy, a healthy baby. So they can go into cardiac arrest because of the very low oxygen or because of respiratory compromise. So this is where you start giving the patient oxygen. If you also look at in terms of the viral status, the replication is down, but you are accumulating viral debris. The viral debris, I am convinced that this is mostly spike protein. This is where our immune system goes crazy, okay? It's in response to the viral debris because your immune system is going to respond in such a way as if there are more viral replication. But in fact, these are all dead viruses. They're just, fragments of the virus. And I think, as I said, it's mostly spike protein. And your immune system will continue to react to that. Actually, the immune system, this is where the immune system freaks out. So when somebody is freaking out, it's going to do something nasty. And this is how you start to, get into trouble. You go into progressive severe hypoxemia, severe hypoxia in the tissue. And then that's the time you start going into the late pulmonary phase. In the late pulmonary phase, that's where you have you go into a full-blown respiratory failure. This, you're gonna have, if you take the x-ray, you're gonna have severe pneumonia, you're gonna have like bilateral infiltrates. Even if you don't know how to read the x-ray, you can see that both lungs are whited out, or lots of patches up and down, left and right. So it's like an extensive infiltrates on both sides of your lungs. This is where you start having, this is the cytokine storm. The beginning of the cytokine storm is in the early pulmonary phase. It becomes full-blown cytokine storm, which includes macrophages, activation. I mean, it's not supposed to be like that. If you kill the virus, it's supposed to end there. But because of all the viral debris, then it continues to keep on going. And what's happening when you have all this macrophage activation syndrome, cytokine storm, and the T cell dysfunction, it is not helping. It's killing or trying to neutralize the available, antigen or the spike protein, but it's also giving you, it's also causing injury to your own tissue, to your normal tissue. And so the most susceptible organ, the one that suffers first, and that's usually the cause of that, uh, the organ system is the respiratory. Both lungs are gonna get. It's like you're drowning on your own, because the lungs become very swollen and become very inflamed, both lungs, and that's where you have, yeah, the acute respiratory distress syndrome. This is what we call ARDS. You probably hear all the time, the patient died of ARDS. That means no matter how much oxygen you put, the patient is not able to absorb oxygen, and therefore it cannot oxygenate any part of your body, especially the heart and the brain. So what's happening there in ARDS, this is when we ventilate them, we put them in the ventilator. This is the time that we even paralyze the patient, because you have to eliminate any type of work, the labor of breathing, any type of work anywhere. And so we tend to paralyze the patient so that only the patient is just very still, and then whatever oxygen we put in, it will go to the vital organs to keep the organism, to keep your body alive. When I say organism, that's the human body, okay? And so the disadvantage sometimes also, if we're not able to lower the oxygen requirement, like we put 100% FiO2 or 100% oxygen, it becomes toxic to the lungs. A lung that is already diseased, and then you put 100% oxygen supplementation, it will also cause some more damage or injury. That's the effect of, because there's so much oxidative stress, and then the formation of free radicals. When you put the oxygen, then it compounds that, and so more destruction. If that happens, unfortunately, the patient dies, and the patient dies quickly. Okay. And when the cytokine storm is systemic, it's all over. It's not just in the lung. The ARDS is, the outcome of having the cytokine storm, but it's also happening in any other organ system. So it involves the brain, the heart, the liver, anything you can think of, the immune system itself, the bone marrow, the kidneys, the muscle, everything, okay, your circulation. And so the end result is a systemic inflammatory response resulting, or the end result is multi-organ system failure, cardiovascular collapse, which is manifested as shock. So there is a what it calls complete collapse of all the organ system, and again, the patient dies. The other component of this late pulmonary phase with the cytokine storm is the formation of blood clots, thrombosis. And so yeah, you have the hyperinflammation, you have all the respiratory failure, and then you have the blood clots forming at the same time. So everybody knows that if there are blood clots, it can clog up any blood vessel in your body, whether it's a microcirculation or the macro one, because depending on the size of the clot, it can happen in the microcirculation that actually a lot of times we don't pick it up in the regular, like let's say CT scan or anything like that, but we know it's happening because when you do the blood test, you will see an elevated D dimer. Markers or hallmarks of cytokine storm, you're going to have markers that are very high. We call them the COVID markers, like CRP, D-dimers, troponin, pro-BNP, and ferritin. These are all indicative of cytokine storm. The IL-6, the interleukin-6. You know, that's why all these elevated cytokines and inflammatory markers are actually the hallmark of cytokine, cytokine storm. And that's each of these cytokines or chemokines and inflammatory markers, they will affect the body in certain way, and then eventually it will cause the organism to collapse. Also, the serotonin, that's another substance that's released by a lot of the immune cell, and it will have the same effect, probably shock, because it causes vasodilation of the vascular beds. Okay, so when the main thing is we need to prevent the patient from going into this state, because this is the state that is very, very challenging to deal with. I mean, we can salvage the patient sometimes, but the mortality rate is very high, especially in old people. In younger people, the mortality rate that we can observe in the intensive care unit is like up to 40–50%, but the old people is higher, at least from my observation. Okay, so when they go in there, once they go into the ICU, the next stop is the ECU, Eternal Care Unit. But that is the uh, the case. Now, if you are lucky and you survive, then you go into this uh, fifth, or the phase 5, and this is the post-acute. In this phase, it's called the long hauler post-COVID syndrome, and basically you have prolonged sign and symptom that's almost the same as the, during the early phase. You get the most important, or the most prominent one, everybody complains of fatigue. And then a lot of my chronic lungers or non-chronic lungers, they have shortness of breath and chest pain. They complain of brain fog, especially the older ones, the older people. But I'm not saying that it doesn't happen in younger people. Actually, the younger ones, they get so anxious, and they have depression as well. They have anxiety, get dizzy, they have headaches, they have muscle aches and pains, joint pains, and sometimes gastrointestinal symptoms. So depending on the presentation of the patient, I would treat them individually. So where to focus, and the fatigue, that is because, in this disease, there is such a thing as, like, uh, we call it mitochondrial dysfunction. And everybody should know, or I'm telling you now, that the mitochondria are those little powerhouses inside the cell. They are the one responsible for producing energy, right? So without energy, you will not have the energy to do anything. Everything that the body, everything that the body does, whether it's thinking, eating, moving, and it will require energy. And your mitochondria, those little powerhouses in every single cell in your body, will be the one to produce the energy that you can spend. And so it's very prominent in this disease that after you finish, or you've been through the acute phase, you're going to go into that. A lot of people fatigue, debilitating fatigue. They wake up, they go to bed fatigue, they wake up fatigue. It's just fatigue, you know? And so you treat them in a slightly different way. And then brain fog, that's also another one. They cannot think straight, they become forgetful, and it's very frustrating, because they used to be very sharp, and now they're not. They cannot connect the dots. Okay, next slide. So that's the pathophysiology. Okay, You guys can have this slide. You actually should. So now, after discussing the pathophysiology, it's very clear to us that the three components of COVID-19 disease, these are the things that will cause death. You know, there's no virus here. Number one is hypoxemia. This is a very low oxygen, and this is due to the pneumonia that the virus is causing, or that the virus is creating through our immune response. So it's like the lungs and the other organ systems are really collateral damage of how the immune system is responding to the virus, right? So when you have very low oxygen, how are you gonna survive? And then the next one is the cytokine storm, which is basically the systemic hyperinflammation or hyperinflammatory response that will cause organ dysfunction anywhere in the body, okay, causing collapse. And then the third one is thrombosis, with basically blood clots. So remember this is how we target the disease. We have to institute or do the treatment targeting hypoxemia, cytokine storm, and thrombosis. These are the major, what do you call this, components of the disease. Next one, please. Next slide. Okay, just to, this is this is a very busy one again. You can see the timing or initiation of the therapeutic agents. This is what I'm saying. This is the basis for applying whatever medication we decide to use on these cases. So as we realize it now after discussion, that really the best opportunity for making a difference in saving lives is like up to at least the early pulmonary phase, right? You have to do everything in phase 1, 2, and 3, or even better if you do all your might in the viral stage, which is the incubation and the symptomatic phase. So if we're able to arrest the progression from there and make the patient better, like in 2 weeks, then chances are you are going to not only save the patient from dying, but you're gonna save them from being very symptomatic and being very, from debilitating effect of the virus. But you have to remember, the higher the viral load, what's the implication? That means that it's more, you can transmit more. Yeah, the higher the viral load, the more transmissible. The higher the transmissibility, the higher the viral load, the higher the chances of you getting sicker. Okay, because the immune response is going to depend on how much it is going to react to. So those are the two things. If you reduce the viral load, you decrease the transmission. If you decrease the viral load, you probably shorten the disease or prevent the patient or the person from getting very sick and debilitated down the road. You can see here, look at the little people up there. You are going to have a lot in the infected, the first infection area. And then as the disease progresses, they're becoming less and less. There are more here. And depending on what you do in the viral stage, then you see you reduce the number of people getting sick, and then even reduce to the early and late. So these people in the late pulmonary, that's about like 15%, probably 20% of the infection of the people infected. And then depending on the age group, the mortality rate is going to vary a little bit, but very high, 40%, 50%, and even higher in older people with comorbidities. And to mention those with weight problems, like the surge that we have now, like in the hospital, the young people are getting admitted, but they are all, it's like obese. 90% obese, they get sick. And the obesity is an independent factor for severity and for mortality, okay? Obese. At least that's true here in America, but I think you have to take note because the Filipinos, last time I was there, I was amazed that there are so many overweight people walking around. When I look, like you go to, let's say, New York, you walk in the street of New York, there's so many obese people, okay? And that's America, that's okay. No, it's not okay, but that's becoming like the situation. We've been like that for, I don't know, more than 10, 15 years now. That's because of the food. And then the Western food went to the Philippines, all this fast food, and that's making our children, gain weight, and not only the children, but the adults. And so that is an independent factor because obese people or overweight people, you develop more inflammation. Okay. And then a lot of times you will also require higher doses of the medication to make a difference. Same thing, when you use ivermectin or any of the other antiviral, for the most part, you will require a higher dose, especially those medications that are what we call lip lipophilic. They love the fat, or they get absorbed. You have to fill up the fat cells first before you can actually utilize the medication and circulate. Okay, so but as you go into the post-COVID, this one is not dependent on your history of hospitalization or history of severity. Even the mildly symptomatic or the mild cases, they are also liable to go in the post-COVID syndrome. And I think it has a lot to do with the medical history and the genetic makeup of the person. Like, let's say, for example, what I'm noticing is people who are going into post-COVID syndrome are those with autoimmune disease, people with who are menopause and andropause, the ones with low hormones. I treat them too, and they go into that. They become very tired, and then their hormone levels are coming down even more after the infection and also after the vaccination. I've been observing that. So, as you can see, what are the medication that we can use for the viral stage? These are the medications that are available right now. The antiviral, which is ivermectin and monoclonal. Monoclonal antibody, obviously, you don't have it in the Philippines. And I use this, I've been using monoclonal body infusion since January. The ivermectin, I've been using it since August of last year, 2020, August 2020. And I started using the monoclonal antibody infusion since January. It was actually approved, no, it was approved to be used under EUA. November, December, I started sending patients to the emergency room for infusion. And then January, I started doing it in my own clinic. As you can see, I put remdesivir here because it's really an antiviral, but I'm going to show you the slide. In the Philippines, they are using this when the patient is already hospitalized and already in either the early pulmonary phase or late pulmonary phase, when they're very sick, they're intubated and all. And so that's the wrong way of using it, because if you look at the remdesivir, it's a viral antiviral agent. It actually suppress or stops the replication of the virus. So if you put it, or if you use it in the phase or the stage wherein there's no more viral replication, how do you expect that to work? And that's one of the things that we've been criticizing. And I've been very vocal about this, that the use of the remdesivir in the Philippines is a little bit, it's almost hideous, because it really doesn't do anything. That's why they are using the hemiperfusion, I think, because of that, because up to 30 percent of the people being treated with remdesivir develop kidney failure, or it's even higher if it is like the older people, the older population. Now, the Paviparivir is from Japan, right? I know it's available in the Philippines, but we don't use this here. You know, we don't use Paviparivir, and that is a Japanese antiviral. The most common side effect of that is it increases the uric acid. So some people will develop gout with this. And then some GI side effects. Now, this eye mask and eye protect, probably the eye mask is from FLCC. The this is basically including ivermectin plus a nutraceutical bundle that's consisting of vitamin D, C, zinc, quercetin, melatonin. No, so those are all immune boosting and antioxidants basically. So you prep your immune system for prophylaxis. We also use that. So you take your nutraceutical bundle, and then you can take ivermectin every now and then, or once a week, twice a week, depending on the infection rate or of the community. If it's very high, then, like, let's say for me, I've been taking the ivermectin twice a week since July, again because of the high infection rate, because of the surge. So I see actual infected people, I treat patient in the office, in my clinic. And so I make sure I take it Mondays and Thursdays. But you can also take it like as needed, for prophylaxis, meaning if you're just staying at home and you're not exposed to anybody coming in and out, then you can take it once a week, or you only take it when you go out. You take it day 1 and day 3. Otherwise, yeah, it's as needed, or if you get exposed to somebody that is a known COVID, then you can take it 3 days in a row. And then if you develop symptom, then you take it like the regular infection dose, which we are going to see a little later. So the monoclonal antibody, we have 3 kinds here. 3 companies. Number 1 is the Regeneron. They're producing the Caricibimab and Dibimab. The Eli Lilly, they are producing the Bamlanivimab and Etesibimab. And then the other one is the GlaxoSmithKline. They only have one, which is I think the Sotrovimab or something. Yeah, that's the GlaxoSmith. We have all that here, but I only have the first 2, but the third one is coming. And the GlaxoSmith apparently is very, very strong for the Delta virus and any other strain. So the monoclonal antibody, it consists of you clone the the human antibody, human antibody, and then it's mixed with the synthetic one. They produce it in the lab. Now, so I put remdesivir there because it should be in the viral stage, but you're gonna give it on an outpatient basis. When you give the remdesivir, you have to monitor the patient very closely, and you need to monitor the blood, the changes in the blood, especially the kidneys and the liver. It can cause both kidney and liver issues, but more common for the kidney. And so that's not allowed at all to be given on an outpatient basis, even though it is purely, if you look at remdesivir, it's purely antiviral. And so it really doesn't make sense that they're giving it on the immune stage or when the patient is hospitalized and deathly ill. the one thing they're also giving it for 10 days. Oh man, that is, yeah, something. So if you want the eye mask, I can project a little bit of the eye mask later, but I would encourage you to go to the FLCC website. We have so much information. It's very easy to search. Even if you type eye mask, it's gonna take you there. Okay, FLCC. The FLCC was organized or was formed by our senior members, Dr. Corey, Dr. Merrick, Dr. Merrick is the most senior, Dr. Corey, Dr. Baron, Dr. Iglesias, I forgot the other ones, I think 5 or 6 of them. I usually get in touch with Dr. Baron. He is in Texas. Now, for the moderate severity, you can already see that you look at this arrow. When the oxygen levels start dropping to 94, that's when you start the methylprednisolone or the steroid. The dexamethasone is very popular because that's the one that was involved in the recovery study. But actually, in our pulmonary world, we hardly use that. The methylprednisolone is much better in the sense that it is much better in terms of the absorption or accumulation of the steroid in the lung tissue. You can also use prednisone, which is oral. The dexamethasone could be oral or given IV. Also, the other problem with using the dexamethasone, especially in the hospital protocol, is that they're using a very tiny amount. They're only using 6 milligrams once a day. I have to tell you, I want to emphasize this. The type of pneumonia that you get in COVID is what we call BOOP. BOOP. It's called bronchiolitis obliterans organizing pneumonia. That type of pneumonia is the response to the hyperinflammation, okay? And so it's a special type of pneumonia that in our world, again, in the pulmonary world, the gold standard is high dose corticosteroid. So if you're going to give steroid, and it's only a baby dose, I always say they're giving 6 milligrams of the dexamethasone. It's like a spit in the ocean. Okay, so it's not going to make a big difference. It will do something, especially on the mild cases or those people who are not intubated. But if you really want to abort, all the inflammation and effect to the lungs, you have to use a higher dose of steroid. And then if the patient is improving, you can taper the dose down. You can taper it down, but the main thing is to break the cycle of inflammation that is mostly deleterious to the lungs, that will kill you. And so that is also the flaw in using that the steroid in the hospital, and that's why a lot of people are still dying, or once they go into the severe state, obviously, and if the patient condition, like in old people, it's really very challenging to recover them. Okay, we also, this is already part, the baricitinib. This is uh, an immune modulator, no? And it is, I will discuss some more of that. I will describe what that is, but basically it reduces the release of the chemokines or the cytokines into the circulation by suppressing some receptors. So when the patient, the indication for this is the patient is not intubated, but using oxygen or high flow oxygen, because the oxygen support is either, your regular flow or the high flow, which means the device is delivering more than 10 liters of oxygen. And the patient will require that much, especially when they already have, the pneumonia, and then progressively. And then again, in the for FLCC, we have the Math Plus, And we have a lot of medication that we include there, is still including ivermectin, and then all the nutraceutical, and then I will show you the other medication that's included and that you can use in this state. And it's the same medication that if you decide to treat the patient in the community or at home, you have to have all those options available for you. Once the patient is starting to go down, you have to use all your guns to arrest the progression of the disease. Okay. Now, if the patient goes into the progressive or severe or critical illness state, then you always have to increase the doses. This escalation of the anti-inflammatory agents, including ivermectin. Ivermectin is not only antiviral, it is an anti-inflammatory, it's an immune modulator, and so it's included there. And we give the ivermectin in all the stages of the disease. So you have to increase the dexamethasone or your methylprednisolone. This is where you start giving. Again, I put red the tocilizumab because this is the only what do you call this, monoclonal antibody that you use in the late stage in the Philippines. Actually, the leronlimab, I noticed that it's becoming more and more common to be used because that's the only thing available. It's sometimes more available than the toci, and then leronlimab is actually, it's a monoclonal antibody, which is a CCR5 receptor antagonist. And so again, it decreases the release of the cytokines when you implement that. It affects, it's originally an anti-HIV agent, and they're still studying it for HIV. And it's supposed to also stop the virus from infecting the cell on top of its anti-receptor, chemokine receptor function. The equivalent of leronlimab here in America, because leronlimab didn't pass here in America because they said that in the study it didn't pass the goal for, number one, the mortality. It didn't affect the mortality at the end of the 28 days, and also it didn't help, it did not shorten the length of stay in the hospital. But there's another related agent which is called Maraviroc, and this is basically kind of the same. I think there is some political issues here because they're exactly the same. This is also a CCR5 receptor antagonist, but this one got approved here in the US, but not leronlimab. And then with this late pulmonary phase, then you have the MATH plus protocol from FLCC. I'm going to project it a little bit later, but I encourage you to look at our site, FLCC site. It is there, but there are a lot of agents there that you can institute if you decide to manage your moderate cases in the, at home or in the community. This is the time that the patient, if you decided to admit the patient at this state, phase, the patient will be in the ICU because the hypoxemia is very bad. Okay. We also use plasma exchange here in the US, so to remove the immune complexes. And then for just a quick mention for the post-COVID, as you can see, this is the one with the persistent low-grade inflammation. I used ivermectin again. I used natural anti-inflammatory. I continued the nutraceutical bundles. Depending on the COVID markers, because here, if you have persistent elevated D-dimer, CRP, ferritin, troponin, and things like that, then sometimes I would give them another course of corticosteroid. Some of these patients, especially the old people, you won't be able to get them off the oxygen, and so they go home with oxygen. I also use high dose vitamin C and high dose vitamin C here. And by the way, in my clinic, I use vitamin C also in all the stages. You have to remember this disease always has this high oxidative stress and inflammatory response. And so you can never go wrong if you start antioxidant. I usually give the IV vitamin C even in the early stages. My patients are so used to that. So they come in and I give them IV vitamin C between 25,000 milligrams, 50, and even 100. Even with me, I don't get infected, but I try to get it every couple of weeks or sometimes every week, depending on how I feel. And if I'm not sleeping enough, so I give myself that. High dose melatonin. This is actually the nutraceutical or agent that can somehow also help the mitochondrial dysfunction. You have to address the microbiome, especially here in this stage. But everything and any stage of the disease, you should give the patient like probiotics, because there are certain deficiency of this bacteria, a good bacteria. When you are deficient on that, you become more susceptible to COVID. I forgot the name of the of the bacteria that is protective uh, for COVID. Okay, peptide therapy. This is something that I do here. This is not outside. I don't know if some doctors. This is part of my functional medicine background. These are actually little injection, sequence amino acid, and I inject them like weekly. And then sometimes you have to send the patient to rehabilitation because they're just very tired, very weak, and fatigued. Next slide, please. Okay, so just to show you, this is the recommendation. This is the recommendation in the Philippines. You can see asymptomatic in stage 1, there's really nothing that they recommend. They will just quarantine you, isolate you, and they just give you some whatever supportive care. If you have fever, then they give you paracetamol, and then I guess you do hydration, but still, I call it the do nothing approach because they're not doing anything on the virus, because they really believe that you're just gonna, take care of it. But in a way, it's true, especially the younger people. But it's much better if you give something at least immune boosting supplements so that you get over it faster and you don't go into a long hauler. But if you look at the recommendation in the Philippines by what do you call this, pismid or something, they don't even believe in vitamin C and vitamin D and zinc and things like that. No, for them there's no evidence, nothing. So you're just gonna tough it out and you're gonna be in isolation, just waiting until you turn blue, and probably at that time you can go to the hospital if there is a hospital bed, and you can get in. And so not doing anything, I think at this stage is a big mistake. And to me, it's very sad to say, but when doctors turn their back on these people who are infected, I think that is it's a big whatever. I don't want to say bad things, but that's not being a doctor to me. Okay. So when you go into the moderate severity, which is the early pulmonary stage, that's the time they would consider, giving you oxygen, supportive care again, and then they use the antiviral. You see, this is where they start the antivirals when I said this is the time that there's hardly any viral replication going on. So starting the antiviral very late, I mean, it's going to do a little bit, but it's not going to do the job because you already have a lot of viral debris floating around. And these antivirals will not do anything on the viral debris because they act on the viral replication. That's the whole idea, you know. And then this is the recommendation when somebody goes into severe or critical illness state, then they still use the antiviral. It's amazing. They do use antiviral. And this is, I got this, you know where I got this? This is from, I don't know if everybody knows Dr. Salvania, but this is his write-up. You know, the antivirals are still being used at the late pulmonary phase when the patient is already severe and critically ill, and there's hardly no viral replication at that point. You might be PCR positive, but that doesn't mean that the viruses are still replicating. And then they use dexamethasone, the 6 milligrams once a day IV or PO. They use the monoclonal antibody, that tocilizumab, and then they also consider the baricitinib at this point. But in reality, the baricitinib, you should start using it in the moderate severity or in the early pulmonary phase when the inflammation is just starting to ramp up. And then they use this hemoperfusion with or without kidney failure. But there are some rationale for this, for using it, because I think the Chinese were the one who did this, some study, but I think the result is like so. Yeah, it's okay, but it could all uncertain benefit, I should say. And then this is the time that, you know, they also recommend ICU admission. And when it comes to the long hauler, I don't think they have any recommendation at all. So you can just get debilitated and disabled, and there's no recommendation that I'm aware of. I might be wrong, but you guys can search your own, you know, NIH or equivalent or the FDA if there's any recommendation for the long hauler. And we're seeing it now, like more and more, okay? And then recovery, long-term sequel. And also here in the recovery or the recovered state, sometimes it's not even completely recovered because there are some people who actually had stroke, some people amputated because they have the gangrene on their hands. So that's another problem there. You know, you're recovered, but you have, you know, deformed body, or you somebody lost extremities, or there's the sequela of the stroke or heart attack or things like that. Or you could be oxygen dependent. You've recovered, but with a sequela. Okay, next slide, please. Uh, I just want to discuss this. These are all the medication that we use. It's not completely, you cannot see them, okay? But you can see that we have anti-androgens, and these are the finasteride. I'm going to show all the list of medication. These are available in the Philippines, you know, anti-androgen like spironolactone, like finasteride, dutasteride, and you can start using them in the symptomatic phase, which is kind of, you know, early, no? So there is benefit, and then even if you already go in the pulmonary or inflammatory phase, there is benefit. So you have to remember all this medication. Ivermectin, you see its benefit in any phase, in any stage of the disease. Obviously, the monoclonal antibody is very strong, but you have to give it early. The the monoclonal antibody will save you 92% of the time. At least that's our data here in Florida, okay? Because everybody, I think it's even higher than 92, because everybody, at least from my experience since January, everybody that I gave the monoclonal to, no hospitalization. So between ivermectin and monoclonal antibody, between the two, I haven't had any hospitalization since September of 2020. Okay, I started using ivermectin in August, and then that was the wild type, still wild type COVID. It responded, the wild type responded to the ivermectin like very quickly, boom boom boom. And so, and I use it massively as prophylaxis at that time to the old people, especially before the vaccine was rolled out. The vaccine was rolled out December here in the States, okay? So the corticosteroid definitely benefit when the patient is already inflammatory phase. This is the thing tend to harm in the symptomatic phase, because as I mentioned earlier, that it tend to promote the viral replication if you give it too early, okay? But you know when to give it, because the oxygen is dropping. When it drops to 94, 95, especially on the high risk, you have to give the corticosteroid by mouth. So that's really the most important thing. When the oxygen level drops to 94, okay? Or even 95 if the patient is really symptomatic. With the Delta, that's what I noticed. I have to start the corticosteroid early, because the course of the disease is like rapid. They start with very short incubation period, because the Delta virus is replicating very fast, and then you have a very high viral load. It wakes up the innate immune system very fast, and you become symptomatic. The inflammation comes in, very fast. So sometimes I would get, on first presentation, I would get patient already having low oxygen levels. So even if it's only few days and the patient is having oxygen level of 94, I am starting the corticosteroid already. And that's one of the things that you have to be um, yeah, aware or conscious about when it comes to the Delta virus, because the what do you call this? The course is fast and it's shortened, so the patient can get into trouble, especially guys. I don't know. I was treating a lot of young males. When I say young males, it's like 60 and below. I've treated so many of the bilateral pneumonia, but fortunately, and with God's blessing, they all survived, but they went through a lot. I didn't hospitalize any of them. They come to the office, or I manage them remotely and make the arrangement. Giving them oxygen, giving them the high dose steroid. I sometimes call the home health to help, and as long as the wife or the husband is with it and aggressive in helping the other person, then it really works. It needs like cooperation of several people, or um what do you call this, organization. Like, if you don't want to be hospitalized, or you get to the hospitals, what they do is they sign out against medical advice, but they go through the hospice. And when you are terminal, and in the hospital, I guess when you are about to have respiratory failure, then they qualify you to the hospice. And in the hospice, you can get all the medications that you need, oxygen, high flow oxygen devices, and then the high dose corticosteroids. So They're able to get around it because if you guys are having problems in the hospital there, we have our own fight. And then the Philippines basically is just following what we do here in terms of the protocol in the hospital, unfortunately. But what are you going to do? So low molecular weight heparin, we need to give them because of the thrombosis. And usually we use the enoxaparin or Lovenox. And we give it subcutaneously every 12 hours, okay? So monoclonal antibody, as I said, it's early treatment. Hydroxychloroquine has already, I don't know, it's out of fashion or something. The remdesivir, there's no benefit at all, okay, as you can see. And this is based on all the study, randomized trial. Interferon, this is hardly used when the ivermectin came into the picture. A lot of the frontline workers, they are taking the ivermectin that the hospital doesn't even know that these people are taking. But that is a nasal spray you put, you spray in the nose when you get exposed. But now the tocilizumab, it's almost like remdesivir. So they said that it made a little difference, but it's almost the same as the remdesivir. So they put unclear benefits, which I agree. The most common side effect or complication of this agent is liver failure. So if you combine your remdesivir, which is the renal failure, and this one is the liver failure, then you're definitely dead. So if you develop both complications. The convalescent plasma or serum is, it was, I mean, we mention it every now and then, but we usually don't use it. I cannot see the last two. I think it's baricitinib, but just like the tocilizumab, it's unclear benefit. And I think there's another one, but I cannot read it. What's in it, G? What's the last agent? That's
Maraviroc.
oh yeah, that's the equivalent of leronlimab. Leronlimab in the Philippines, but that agent, both of them are CCR5 antagonists or inhibitors, and the leronlimab was kicked out of the US, so they went to the Philippines, but we have somewhere, the Maraviroc is only accepted to be used when it is in the trial, okay? All right, next slide. Let's see, so that we can have some discussion and we'll finish this. And these are the things that I was talking about. These are all the monoclonal antibodies. You have to be aware of this because eventually it's going to catch up with you. This is what I am saying. This is the early treatment antiviral monoclonal antibodies. People are getting confused with this. When they say monoclonal, they think about something else, not the early treatment monoclonals, the antiviral. These are neutralizing antibodies. So it's like getting a vaccine is effective right away, okay? So you have the Regeneron, Eli Lilly, the GlaxoSmithKline, it's Sotrovimab. So this is very good apparently for the Delta virus, but the Regeneron, Caricibimab, and Dibimab, they have to be together to be effective in all kinds of the variants. And Bamlanivimab, Itazimab by Eli Lilly, they need, that's why they are called cocktail, because there are at least two antibodies. One is the natural one or the cloned one, and then the other one is the manufactured or synthetic antibodies. For the severe disease, or they act as immune modulators or anti-inflammatories. Here we give the tocilizumab, which is an anti-IL-6 receptor antagonist, and the what do you call this? This is the interleukin-6. When somebody is in cytokine storm, the interleukin-6 is like sky high. So that's one of the marker, together with the high ferritin, high D-dimer, high troponin, and high pro-BNP. okay, and ESR sometimes, but the CRP and this and the D-dimer, very bad combination. When you have an elevated troponin, then your heart in in trouble. Okay, and this is another one. This is the one that's also substitute for tosi, the sarilumab. Oh my goodness, it's all this mab, okay, the mab are the antibodies. So this is another anti-IL-6, and then this is the third one that's still in clinical trials here in the US. And then, as I said, the maraviroc is a CCR receptor antagonist, and leronlimab, this is the one that's available in the Philippines. I've used this in a few patients when I help, or I was helping some of the doctors there to manage some people who are very sick. So I've given this. This one is the leronlimab. This one is oral. I think it's 300 to 600 milligrams twice a day for 10 days, I believe. We're going to correct that, okay? But the leronlimab is sub-Q. You inject it subcutaneously here in the belly, under the skin. The first dose is like 700 milligrams, and then you follow with another 4 doses, a total of 5 doses every week, 350 milligrams of that. So if you have a very sick person, and we've treated people even at home with that, because the patient didn't want to go to the hospital, but has the ability to actually purchase leronlimab, because it needs just the prescription from the doctor, and then you can get that and you can actually give it to the person at home because it's subcutaneous, no? And then baricitinib and all the other immunomodulator. So the baricitinib is being used more and more in the Philippines because it's easy, because it's oral. Usually that's 4 milligrams every day, daily for 14 days, but it needs to be adjusted to your kidney function. If your kidney function is more than 60, the GFR, then you can use the full dose. But if it goes down below that, up to 30 or 30 at least, then you have to half the dose. And if it's lower than 30, you can even 1/4 the dose. And if the GFR is less than 15, you don't use it. Okay. Okay, next slide, please. We'll make it. So I made a list of all the medication that is actually used in moderate to severe, and a lot of this you can use it in the outpatient if you chose to, and if you are forced to manage the patient in the outpatient, these are the same agents. There's a second page on this, and for those of you who want the slide, then G, you can just distribute that, okay? So you can see methylprednisolone, high dose ascorbic acid of vitamin C. When I say high dose, if you look at the FLCC recommendation, they are only recommending like 25 grams twice a day, every 12 hours. I use more than that. I've used many times up to 100 grams or 100,000 milligrams, but it depends on the level of comfort of the physician. You know, if you have the experience, then you're going to be much more comfortable, and it can be given outpatient, okay? Because I do it outpatient. People are coming to my office to have IV vitamin C for different reasons, for health maintenance, for autoimmune disease, for chronic fatigue, for cancer. For cancer, we use much higher doses. I will give up to 100, 200 grams 2 times a week, 3 times a week, depending on what the patient is doing, if they are getting chemotherapy. But don't use it if you don't have the experience, please, because the patient that I use this to, I know them very well, okay? I know their medical status, I know their blood works, I know it. And so it's a calculated risk when I use that, but the higher dose are reserved to the cancer patient, okay? And then you have to use anticoagulation. You can also use on an outpatient the aspirin and then the anti-10A uh, inhibitor, like the oral form, like Eliquis, Xarelto, Pradaxa, those kind of agents to anticoagulate, sometimes in combination with the aspirin. Okay, ivermectin high dose. This is already the latest recommendation of FLCC, 1 milligram per kilo, and this is because of the Delta virus. Okay, and I'm going to tell you again the level of comfort in using high dose ivermectin should, it's provider dependent. I've used much higher than that, and again, as the patient didn't have any other choice, no hospital bed, they're in the boonies or something, and that's the only agent available. And we're talking about patient in the Philippines, and I've used much more than that. I'm not going to tell you, but higher, much higher than that for a prolonged period of time. And these people are in ARDS, full blown. Okay, this nitazoxanide, this is a new one. Actually, here in the US, this is so expensive. The 5 day to 7 day treatment course, it costs like 2,500, like 5 to 7 day treatment. But I tried it with my insurance. They gave it to me, so I have one bottle. But the cost, if you're gonna do it out of pocket, is 2,500, even up to 3,000. But I think you guys have to, what do you call this? You have to research and be resourceful, because it might be different with you. Here in America, if it's not very commonly used, and there is a big disease that it is being used for, they just, they can dictate whatever cost they want, whatever price they want. Now, so that is also an early treatment. You want to use that in also early treatment with the Delta virus, but you can still use it moderate to severe. And then melatonin, 10 milligrams. I use much more than that. Okay, the highest dose that I've used for melatonin is like 6 to 8 milligrams per kilo. That's very high. That means giving the very sick person, like 150 milligrams every every 4 to 6 hours. And so I've used that, but this is a very sick person. We're just using everything. You're like throwing in the sink, you throw the sink to the sick person just to save the person. So thiamine, this is another one that this actually helps, improve the oxygenation. You have to give it IV, 200 milligrams every 12 hours, at least 3 to 5 days, and you can reduce it to once a day until the patient gets better. As I said, aspirin as part of your anticoagulation. The cyproheptadine, this is a very old antihistamine, and this is anti-allergy. And the purpose of this is to reduce the release of serotonin, which is another, of the substances or chemokines that's released by blood cells, by the white cells, that can cause, vasodilation and severe reaction, and that can put the patient into shock. When you have a severe release of that, actually, that's one of the mechanism of long hauler, when people have low grade release of serotonin, and so we use that. The other, I think, the other alternative for cyproheptadine is Montelukast. Montelukast, 10 milligrams once a day. We use it for asthma, allergy. So if you cannot get the cyproheptadine, you can also use Montelukast, okay? And you can also try the other anti-allergy like the Allegra, like the Claritin or Zyrtec. Again, you see, I mentioned this already, the anti-androgen, it reduces uh, the has something to do with the virus again, and it reduces the this is like anti-cytokine. We have to review the exact mechanism of this. This is something new that we just added in the FLCC. This spironolactone, everybody knows that this is actually a diuretic, and it's a very old diuretic. So a lot of these are repurposed medication. Dutasteride is an anti-testosterone. We use it for prostate issue. And finasteride is the same way. The finasteride, you can actually use it in female. And I use that off-label for hair growth, okay? The finasteride. Okay, next, we'll just do that. Okay, these are the rest, you know, B complex. Fluvoxamine, this is an antidepressant, okay? And you can also use this early, you know, at the beginning when the patient is becoming symptomatic. Usually it's 50 milligrams BID. This is an SSRI, serotonin release inhibitor, and this is an antidepressant. And the person who did a study on this extensively is Steve Kurtz. He's the talkative, flamboyant millionaire here that we have. And he is very vocal. He is out there going after FDA, and he goes to the Senate and then start talking about all this early treatment agents, and he's so against the vaccine. And then you can also substitute fluvoxamine with fluoxetine, and that's another antidepressant. Cholecalciferol or calcifediol, you know, I don't know if it's available in the Philippines, but this is the IV form. Usually we use the vitamin D, but it takes a little bit for that to act because it needs to be converted, no? And so it's much better if the patient has already been taking the vitamin D prior to the infection as prophylaxis. I use much higher than that. I usually use 50 milligram, no, 50,000 international units. I give them 5 days in a row. You know, this is a natural anti-cytokine or immune modulator. You guys have to remember the vitamin D is not a vitamin. It's actually a hormone. This is the only vitamin, so-called vitamin, that can actually go into the cell, into the nucleus of the cell, and actually influence what the cell is going to do. So like, let's say, for example, it goes into the T lymphocyte. Instead of producing the IL-6, it will produce other IL, either 10 or 8, that will not be detrimental to the human cell. So that's very important. So if there is something that the public health message should say, that's that. Everybody should take vitamin D. Okay, everybody. Aside from the sun, you cannot get enough from the sun because it's a little bit tricky from the sun. The most that you can get from the sun is 1,000 international units, you know. So, and it also depends on what time of the day, or where are you, how far are you from the equator or something. But if you're at the right location, right time, it only needs 15 minutes of exposure to the sun to get at least 1,000 international unit of vitamin D. Now, fish oil, Labasa, Basepa, these are our brand names here. You can have your own fish oil there. That's anti-inflammatory. Atorvastatin, which is actually a statin medication, supposedly help, again, anti-inflammatory. You have to give some magnesium, either orally or IV when the patient gets very sick, because they tend to have magnesium deficiency. And if you have magnesium deficiency, the ramification or the complication is so much. They become very weak. You can have arrhythmia. And so when the patient is very deficient in magnesium and you give some of this medication, you can actually create a regular heartbeat that can put the patient in trouble. And it's not that it's the ivermectin or the fluvoxamine, but the patient was magnesium deficient, and so it became the heart became more susceptible to developing the irregular malignant heart rate. Magnesium deficiency by itself can cause you to have what we call ventricular tachycardia. So if you don't replace it, then you can get into trouble, okay? Famotidine is another one. It is an H2 blocker, right? So it's again an old medication. Aside from being an H2 blocker, histamine release, okay? It is also when you're giving anticoagulants, aspirin, or the other anticoagulants, it can obviously protect the gastrointestinal tract from the effect of the acid. You know, when you're very sick, the acid production in the stomach becomes very high, and actually this severely ill people will develop what we call Cushing ulcers. And basically, I'm giving you the complication that we see in the ICU. Cushing ulcers, and they develop like ulcer in the stomach, and they can bleed, okay? Again, Maraviroc, but this is only, oh, you see it's 300 milligrams BID for 10 days. This is oral, but it should be in the clinical trial. And then leronlimab in the Philippines. And then baricitinib, it's already like a protocol in the hospital. Those people admitted in the hospital requiring oxygen, not ventilated, not the ventilators, but the oxygen, including the high flow oxygen, using the high flow devices. So you treat that baricitinib daily for 14 days to be adjusted according to kidney function. Sometimes there are some people, especially the doctors. I have a friend, he got COVID. He didn't want to stay in the hospital, so he was discharged with that. But he got into trouble just the same because he's a doctor and he's a bad patient. He's my friend. Okay, next. I know we're the worst patient, the doctors and the nurses. Okay, so this is the new eye mask for the prevention of Delta. You will notice already that, I mean, here they're still using the 0.2 milligrams per dose to be taken twice a week. I don't use that anymore. I use 0.3, but you can still use that if you want, and you have to take it twice a week, you know, when the infection rate in the community is high. And so for the post-COVID exposure, you see, you have to use 0.4 because, as I said, the replication rate of the virus, of the Delta virus, is high, is fast. And then, so you have ivermectin, and I definitely would use the 0.4 in the overweight people, even for prophylaxis when somebody is kind of big, more than 200 pounds, BMI of 35, BMI of 40. So in the medical record, I always identify patient height and weight and what's the BMI. When they start BMI of 25, because in our medical record, if you plug in the number, it automatically calculates. I'm going to bring the EMR to the Philippines eventually. I'm bringing it already. I'm training some people in Bacolod. They're working with me. So it's very nice because in the electronic medical record, you just plug in the number, it gives you some other useful information that you can use in the treatment. Okay, and it's still the same thing, the immune boosting and fortifying, they call it supportive therapy, your vitamin D. I use maintenance 5,000 for my older population. I don't use 3,000. I use 5,000 daily. And then the vitamin C, the higher that you take it, minimum to 2,000, 3,000 a day. And then same thing with quercetin, yeah, once a day. The zinc, you have to be careful with the zinc when you use it when you're not sick, because if you use higher doses of the zinc, then you are liable to develop copper deficiency, and that's going to be another problem. So some of the zinc that I use, it's already mixed or it has the copper in it. Okay. So I don't know if you guys have that there, but you just have to be um, careful with that. And the quercetin, if you are using high dose, apparently it can increase the level of ivermectin. So it's okay. But you still have to be careful, especially those people who are like very courageous and they are using high doses of ivermectin. I know some people in the Philippines are using that without the doctors on board. And so the doctors have to be on board because the cases that we're getting, they are sicker and they are older too, and they have a lot of comorbidities. They have polypharmacies. We have to be aware now that we have more experience with the ivermectin, and so you have to be. I emphasize that in the huddle, that it's not anymore completely interaction free. We are recognizing it already that it can interact with the blood thinners, especially Coumadin. It can interact with antiarrhythmics, which is like the most common is amiodarone. And then anything that ends with the nib, not baricitinib, but the other nib. Okay, there are some antihypertensive like the calcium channel blocker. I think nifedipine is one of them, and I think there's another beta blocker. You have to go to the FLCC website and you are going to see the link that will bring you the interaction of ivermectin with the other medication. But one thing is, I don't think that they are most commonly used medication. Oh, interaction with the antifungals, the azole. When you see the medication ends in azole because that is antifungal, or medication that I said anticoagulant, antifungal, anti-seizure medication, the phenytoin, which is the number one medication. It's very old, but it's number one medication that's being used for seizure, no? And so it's not a complete contraindication, but it can make either the ivermectin level high or the phenytoin is going to be high. So you're going to have toxicity from either or, because the idea is all this medication are actually being processed or metabolized in the liver. And so they are going to compete. And a lot of times the ivermectin is favored. And so the ivermectin will make the level or the blood levels of the other medication higher. And so it's not the ivermectin per se making or causing the complication or the side effect or the adverse reaction, but the effect of the higher levels, blood levels of the other medication. Is that clear? Clear. You have to go there. And so, okay, next slide, please. I think we're almost done. Okay, just to mention, these are, you see, the early treatment, the Delta variant, you have the nitazoxanide. You really have to find out where you can get nitazoxanide in the Philippines, because it might be much cheaper or more reasonable than what we have here. But if it's covered by insurance, then it's not a problem for us because it's 100% covered. And then mouthwash again, and then it's the same thing. Okay, this is the nutraceutical bundle, and then quercetin, and you can use this in an outpatient basis. Okay, next. And then again, second line agent, the mention of anti-androgen therapy, spironolactone, dutasteride, finasteride. These are available in the Philippines. So you can start using this in conjunction with ivermectin. Fluvoxamine, I think your source of fluvoxamine is not from the US. I think it's from Malaysia, Singapore, or India. So I know that some of the Dr. Homer has this. He can compound this, the fluvoxamine. Okay. And then again, the monoclonal antibody, it's second line agent, but in my office, this is first line. Anybody that I qualify will get this. Once they become symptomatic, they come to my office, they get tested on the same day they get the treatment. Ivermectin monoclonal. Nobody gets hospitalized. Okay? Nobody. I have 0 hospitalizations in September. Next. Okay, this is just, I listed all this, the one included in the math plus. Don't hesitate to use any of the agents in the math plus. This is actually hospital medication, but if you're gonna learn the moderately severe, COVID in the outpatient, which I'm doing now, I'm actually doing now, but the advantage, my clinic is set up in a special way. I can practically give any medication they give in the hospital, except remdesivir, because it's not allowed. It's illegal to do that in the outpatient. Tocilizumab, same thing. But I think there in the Philippines, I don't know if you can get away with it. Probably some people are, those who can afford it or something. I know some people who are doing that, but not everybody can do it. So you have to look at the list of medication included in the hospital treatment. Nobody's going to tell you. And by the way, this is the FLCC protocol, okay? This is not the recommendation from the FDA or NIH or anything equivalent in the Philippines, because I showed you the recommendation earlier. It's very, very straightforward. Remdesivir, tocilizumab, hemoperfusion, and oxygen and dexamethasone. Those are just the 3, 4, 5 agents that you can use, whether it's in hospital or you're able to get it to be used in the outpatient. That's all. But in the FLCC, there are so much more, you have so many choices that you can use because a lot of them are oral. The IV vitamin C, you can use it in the outpatient as long as you have you're able to get the solution, the IV solution and the IV vitamin C, you can mix it, and there's a nurse or anybody, a doctor can put it on the patient, and you can give it to the patient over like 2-3 hours, and then with that you can also hydrate the patient. Okay, next. Next, let's see. So the same thing, this is another, the rest of the agent that you can use outpatient, but this is actually our hospital protocol. Look at this. These are all by mouth, right? But it's being given in the hospital at higher doses, so nobody's going to stop you from giving that to the patient on an outpatient or in home care, especially if you have a nurse. I've managed quite a few already in the Philippines, and they are, taking care of their sick relative at home with a nurse. Okay, next. Okay, some more. I've listed this. You can get all this, and you can go to the FLC site, and then you can use any of this agent. Next slide, please. Okay, next slide, please. Basically, this is just saying that, you can, the oxygen, obviously, you have to make sure that you have source of oxygen if you're going to treat the patient at home or, in the outpatient basis. Next, please. And I just want to show you the ivermectin. I keep on saying ivermectin because this is the medication that we use in all the phases of the disease. The ivermectin here in the US is commercially available as 3 milligrams and 6 milligrams. So when we get it from the regular pharmacy, if the patient requires 30 milligrams, then the patient is going to take 10 tablets of the 3 milligrams, or how many, 5 of the 6 milligrams, or 5 or something, or yeah, 5. And then the compounded form, you know, like the regular, the smaller pharmacy, then they come in 3, 6.
Wala raw clinic bukas. Wala raw.
So
Pero,
okay, 3, 6, 12, 15, 18, and 24 milligrams. So we have all that. And then, you know, depending on the weight of the patient, then you will have to select which preparation you want to use. Okay, next, please. Oh, this is just a little example how you compute. Because over there in the Philippines, they are saying, okay, you have to take 3 capsules. And they're not telling me what capsule, 15, 12. They're so used to, I think they just assume that it's all 15 milligrams. I mean, it's also okay, but I'm not, in my head, I'm not used to that because I use all of this preparation. So what I do is, if it's like, let's say 12 capsule and the requirement is 28, it's, you know, it becomes 36. So I round it off to the higher dose that it comes out to, because I don't want to underdose the patient. If you use 15, 2 capsule for 28 milligrams, but it's 30 milligrams, so I just give the 30. I mean, 24, if you use 24, it's too much, but you know, if the patient is heavy, I'll use the 48. So it's an example. I round it off to the higher dose. You know, when you, because we have all this different preparations, so I work with whatever is available. So if you have 18 milligrams capsule, you have to give 2, which is kind of 28 is the requirement, and you give 36. That's still okay. You can give that. Yeah. Okay, so I think that's the last slide. Just want to show you that. And now Q&A. And what's next on that? Are there any more slides after that?
It's Q&A, man.
Yeah. Okay. That's the. If you have a specific question that you are managing, ask them now, so that, because you know, when you manage cases, it's case to case. I do different things with the available resources that I have. Sometimes I use almost all of them, all the things that I've shown you. It's a hospital protocol, but that doesn't mean it will stop you from using it in the outpatient. That's why I'm able to stop the patient from getting hospitalized, because I give them that. And then, you know, it's a little bit, you know, scary for the patient, because they cannot, it's the breathing that gives it away. You know, it's difficult to watch your loved one, you know, gasping for breath. But if you are able to use the high flow oxygen, it's going to save them, because even if they have a little bit of difficulty breathing, as long as the oxygen is able to go up to 94, 95, they're going to do well. And then if you have IV available, and then that's that. So question, let's do the question.
All right. Doc, we have a very long list of questions in the chat. So,
Okay, okay.
well, the
Yeah.
first one, I think you've tackled it, but you might want to say something about it. What can be done with patients who are long haulers? It's posed by Queen.
Yeah, as I said, it depends on the presentation, but the mainstay is I give them ivermectin. Sometimes I repeat the entire course as if they're having acute COVID, and then after that I maintain them 2 times, 3 times a week until they get better. And then you have to use, if they're very tired, I give them IV vitamin C almost weekly. It depends on what the patient wants. It's better than nothing. They come to the office, they get IV vitamin C because they need a lot of antioxidants. Remember, I was saying to you there's a low-grade inflammation in the long hauler. And also there's this subset population that they are, that has something to do with a serotonin. It's a serotonin activation syndrome. They are patients that are already having problems even before they got the COVID. And then when they got the COVID, it becomes even worse. And they have this continuous release of serotonin. And so you have to give them antihistamines and stuff like that. You have to manage their diet like crazy. You have to identify what food they can and they cannot eat. So it's like a detective work, you know, and there's this normal, no history of anything, and they just present to you like fatigue, brain fog. So for the brain fog, we use the fluoxetine and the fluvoxamine, because you have to remember the ivermectin doesn't we call this past the blood-brain barrier, no? But the virus can. It goes in there and it stimulates the alpha receptors and it will release the chemokines even in the brain. And so you get brain inflammation and you have to suppress that. So it seems like the fluvoxamine is working, and I give them high dose melatonin, just the same, the high dose vitamin C. It depends on what's the presentation, but I give ivermectin as mainstay until they get better. Because when you give it to them, you have to prevent them from getting another COVID anyways, you know. Some people, they don't believe in continuing the ivermectin after the acute infection, but you have to make a clinical decision when it comes to that, okay? Because especially the old people, I mean, whether we like it or not, they get vaccinated, they had the COVID, they still get the infection again. Probably the infection is not as bad, but with the vaccinated old people, they can go into still severe disease just because of the antibody dependence enhancement type of thing, you know? So the old people, they really are the most vulnerable and the risky group, however you want to see it. They are the one that they are the one that need to be protected. Okay, is that all right? Go to FLCC again. There is like a little guide which is called I Recover. I really would like you to go to the FLCC and look at that. Okay, especially the doctors. You know, you can read that and then make your clinical decision which one will best, you know, which one is suited for the patient. Okay.
Okay.
Next.
The second one is, how do you measure viral load in the first phase?
Well, you can either, number one, if you do the PCR and you set it at a lower cycle, because a lot of, in the beginning of the pandemic, they were setting it at 35, 40. It's going to be positive all the time if you do it like that. But if you set it below 20 and it becomes positive right away, you are most likely looking at a very high viral load. Number two, if you do the culture, but I don't know if you have facilities there or hospital doing the viral culture. Number three, what's the other one? The patient really gets sick faster. You know, the patient just present to you with like 3-4 days of symptom, 3 days of symptom, and then you look at them, the oxygen level is already low. And if you have the ability to, you know, do the COVID markers right away, I'm going to tell you those D-dimers, those ferritin, the CRP, they're all going to be very high, because the COVID, the viruses will stimulate your innate immune system very early. You know, the inflammation comes in very early. So it's like an indirect, way of looking at it. Just because, like, let's say in my case, I've treated so many already. So You can almost see. You ask them, how many days have you had symptom? Oh, 3 days. And they're already sick like a dog. So they're very sick. And then, so must be Delta. Yeah.
Right.
Okay. Next.
Then, there's a question. Are protocols different for vaxxed and unvaxxed?
Mm. No, not really. Actually, when the vaccinated, especially again the older folks, if they get sick, you have to be very aggressive with them, because when they are vaccinated, chances are they have more mutated viral load higher in their nasopharynx. That's number one. Number two, you don't know who's going to do the ADE. Do you guys know that? You've heard that, no? The antibody dependent enhancement. What's happening after you get vaccinated is supposed to protect you. You have neutralizing antibody, but in the ADE, instead of the antibody protecting you, it's actually facilitating the virus to infect more. So the infected person becomes very sick. So not everybody will produce ADE, but if you're vaccinated, so it's like getting the vaccine is like a Russian roulette. After the vaccine, it's another Russian roulette for the ADE, something like that. And so to me, especially for the old people, the vaccine is another risk factor. Is another risk factor to me. I'm seeing that more and more. The vaccinated one, when they get sick very fast and very bad, and they die faster as well.
Okay.
Okay.
Number
The
okay.
older people, okay, the older people, but it can happen in young ones too, but you know. Okay,
All right.
next.
There's another one. I think why saliva test is still positive after 21 days.
Yeah, those are the viral debris. I mean, the PCR test, are you talking about antigen or PCR? The PCR can be positive up to 70 days, but that doesn't mean you have infection. And that's why if you're not symptomatic and you want to confirm infection, I don't think that the PCR is the best test to do, because the PCR was never developed to detect infection, because it can detect anything if you cycle it high enough, right? If you are more than 35 to 40 cycles, you test somebody, it's going to be positive. 9 out of 10 will be false positive, the PCR. Okay. Yeah. And that's why, there were so many positive, because, you cycle it at 35, even though you don't have infection, it still turned out to be positive. And so they're saying, oh, there are carriers walking around and blah, blah. But actually, the true asymptomatic infected people are the pre-symptomatic, the incubation period. And that's only for a few days. So they are asymptomatic, but eventually they develop symptom, goes into the symptomatic phase. But the real, it's not really a carrier, except now with the vaccine, it looks like they have carriers already. But the asymptomatic infected are actually, they are infected, but they're in the incubation period, which is the pre-symptomatic period, which is a few days. But with the Delta, it could be very short, okay? Because it's fast. Okay.
Okay. In the Philippines, doctors are not comfortable giving high doses of methyl. I suppose this is methylprednisolone due to spike increase in sugar. What is a comfortable dose, and is it based on weight?
The comfortable dose to me is something that will relieve the patient, okay? Yeah, that's why they have to start getting comfortable with it. And that's also one of the things that I notice over there. I know I try to co-manage with some people, and these doctors in the Philippines, I don't know why they don't want to talk to me. I'm not gonna take away their job. Yeah, because the relatives would like to consult, okay? And I'm talking about even pro bono, okay? It's like the legal thing. And they just want, I said, it's much better if you guys can arrange for me to talk to your doctors. You know, in the hospital, nobody wants to talk to me. It's like so weird for me. I mean, they don't want help. They don't want, I don't know. It's so weird to me that they don't want to talk. Why? And the one, they would communicate with the family, oh, they're not comfortable with this. I said, you know, it's useless for me talking to you if these doctors are like comfortable for nothing. I mean, if I tell them what to do, I am going to solve the problem, whatever comes out. Because when you have a very sick patient, the first thing that you have to have in mind is how do you keep the patient alive? Okay, the patient is diabetic, and then you are going to give the high dose steroid. Number one, if you have to use insulin a short period of time, sub-Q, the regular insulin, that's why you have to learn how to manage as if they're in the hospital. The people who are developing high sugar may need hydration, because they can go into what we call hyperosmolar state. Okay, the patient is going to have very high sugar. You're not looking at the patient is getting dehydrated, and they get confused because the sugar is very high. It's called hyperglycemic hyperosmolar state. And then if you're not looking at the patient is not eating, becomes confused, you're going to hospitalize the patient, not because of the COVID, but because of that. So like if they are on insulin, they have to be given a higher dose. And then you have to put them on a zero carbohydrate diet.
Okay.
You understand? Zero carbohydrate diet. And then a lot of times it's better if you put them temporarily, if the sugar is really very high, you need to make sure they're hydrated. If you have to put them on sub-Q regular insulin, you have to do that. Because we're talking about you learning, managing the patient outpatient with a hospital approach because the patient is sick enough. So you cannot be like, oh no, I'm not going to use the insulin because the patient is at home. I know what kind of thing is that? What? I mean, I guess I'm talking like this because I've done so many sick people, and but when are you going to start getting comfortable? When a lot of people are dead and a lot have died already. This is what I've been pointing out in the huddle, that the landscape of treatment for COVID has to change for out of need and necessity. Because if you have so many high cases, what are you going to do with the very sick people? They're going to get into the hospital because there are no beds. So you will be forced to manage them. That's better than doing nothing. So you have to do it. You just have to recruit the help of all the family members. And then if you can get, somebody to administer the medication, you do that. I know it's uncomfortable, but so what? It's uncomfortable. Make it comfortable by exposing yourself more into that. You don't do it, you will not find out that it's okay. What can I say? But obviously I understand because I have more background, training and experience. I have more background, so it's very easy for me to talk. But it's not that difficult. You have to make a decision. As a doctor, you have to make a decision. Are you going to help? Are you going to try and help this patient? Are you going to keep this patient alive? Then do whatever you can. Nobody is going to blame you. I don't think so, especially if you really want to help. That's better than letting the patient die without a fight.
That's true. That's true.
Okay. All right. So that's the thing to that. Put them, even if they're not diabetic, put them on a zero carb if you're giving them high dose steroid. And yes, I'll emphasize it. The pneumonia that you get from COVID is a boop. Everybody say that. Boop. B-O-O-P. Boop. That's what it's called. It's a bronchiolitis obliterans organizing pneumonia. And the classic presentation of that is very bad hypoxemia. They become hypoxemic very, very fast. And then it's caused by the inflammation that you see in the lung. It's hyperinflammatory response. Okay,
Okay.
next.
Here, there's this Dr. Dimitri Katz who is advocating niacin and melatonin for COVID treatments. He says that a lot of people have neurotoxicity issues because of ivermectin. What is your take on this?
No, that's misinformation. There are only few situations where you can have neurotoxicity. First of all, number one, the ivermectin doesn't cross the blood-brain barrier. It will only cross the blood-brain barrier if, number one, in studies in Africa, South America, if they are heavily infested with a parasite. When you treat them, the blood-brain barrier is kind of open. So the ivermectin goes into the central nervous system and then kills the parasite, and then it creates more inflammation and they become neurotoxic. Number two, that it can pass through the blood-brain barrier if you have a mutation of the MDR gene. The MDR gene is the one responsible for that glycoprotein that guards the blood-brain barrier. That's the one that keeps the toxins out of the brain. So if you have a mutation and it becomes leaky or open, then that's the time that the ivermectin is going to go in. Number three, so any inflammation, you have active meningitis, you have active encephalitis, I don't think that is a good idea to give the ivermectin, because chances are it may would pass the blood-brain barrier. So that's somebody who said that doesn't know the what do you call this, the kinetics or the mechanism, how it goes through the blood-brain barrier. When they were testing ivermectin for cancer, you know what? It had an effect on any cancer in the body except the cancer in the brain, because it doesn't pass, okay? So the blastoma, anything in the brain, it didn't affect. But talk about breast cancer, lung cancer, gastric cancer, what do you call this, muscle cancer, anything, GI cancer, somehow the ivermectin had some effect on it because it can go through. But the brain cancer, no, it did not have any effect, for the sole reason that it doesn't pass the blood-brain barrier. So tell that doctor, please read some more.
Next, what happens to the lungs after COVID? Do the lungs go back to its previous state, or would you have damaged lungs for the rest of your life?
Okay, yes. It's like this, depending on the degree of inflammation, uh, and depending on what kind of lung function you're talking about at the time of infection. Because if you go into ARDS, you go into the pneumonia, the BOOP, it will have fibrosis, okay? And so that fibrosis, some of it will come back to a normal tissue. So it's not fibrosis, because once you become fibrotic, it doesn't come back. The lung tissue, unfortunately, doesn't grow back. But, we can function normally depending on what's lung function left, okay? There's a minimum lung function that you should have. We call it FEV1, which is 1 liter. If you have a liter of lung function or a little bit more, even though you had a lot of fibrosis or a lot of scar formation from the COVID lung, chances are you would be able to function comfortably or resume a normal activity, whatever is normal for you, because you still have that amount of lung function left. So when I see patients who were very sick from it, once they recover, I make a new baseline of lung function. Baseline, their ability, how much is left, their ability to absorb oxygen, those two things, okay? So we work on that to improve their physical activity tolerance. So Yeah, it can. And some patient, like let's say if the patient already has an existing lung disease, that's going to be very challenging. Like the patient got infected and the lung function is already less than 1 liter, we're going to have a respiratory cripple. Meaning if that patient survive, is going to be on oxygen supplementation probably for the rest of his life, or the use of non-invasive ventilatory support. We have CPAP, we have BiPAP, we have Trilogy, we have those things here. And so I give it to them. And then sometimes they can just use the oxygen during the day, and then they use the non-invasive ventilatory support at night, or sometimes intermittently during the day plus oxygen. So it depends, okay? But you can always optimize whatever is left. Okay,
Now,
next.
about the use of, I don't know how to say this, doc, colchicine.
The colchicine. Okay.
Yeah, colchicine. Do you
Okay.
suggest it to obese patients, though?
Yeah. In what do you call this? In our assessment based on the randomized trial, the benefit is supposedly unclear. Okay. But if you talk to the Indian, the Indians from India,
Yeah.
there's a doctor there. I forgot his name, but I've watched him one time. He seems to be very intelligent. He is so comfortable using colchicine, different doses and different stages, except for the severe one, no? But he's using it like ivermectin in the area. And his record is also very good. He's treating everybody. I forgot his name. If you ask the Indians, and a lot of them are using colchicine because it's even cheaper. Yeah, they have good result apparently. They should put that into paper. But here in the US, I hardly use that. But sometimes I do. If they cannot afford the baricitinib or what have you, I would combine all of that, colchicine, ivermectin. You just need to be careful because GI effect. You know, some patient is very fast for them to develop the diarrhea. It's very uncomfortable. They develop diarrhea from the colchicine. Actually, when you treat gout with colchicine, you know when to stop because the patient is going to have diarrhea. That's a signal that you have to stop. And so my experience with colchicine is intermittently, but this guy I was listening to, I'm listening to him, you know, he has the experience. What can I do? I mean, he has treated 1,000 already, just like I've treated people 1,000 with ivermectin. So that's the thing to that. You can use it or not, you know, anything that will help the patient, because it really, if you look at the action of colchicine, it really affects the cell division. So if you're able to stop that, then the white cells will not divide and go crazy, and it stops the inflammation eventually, you know. Okay, that's
Here,
the answer to that.
the next question is, earlier you mentioned that vaccines become a risk factor to seniors. What do you suggest to recovered from COVID unvaxxed seniors for protection? Should they get vaxxed or rely on natural immunity and do IVM prophylaxis as needed for
Yeah.
peace of mind?
Yeah, those people who number one, okay, if the thing that I'm going to talk from my own experience, okay, I've been treating vaccination complication for a lot already since December or since the beginning of this year, because they rolled out the vaccination like December or November. And so after that, I started seeing complication. And the complication of the vaccine, the most common is the long hauler. It's exactly the same as the long hauler of the acute COVID. Okay? It's like getting the acute COVID without the viral stage. You understand? If you test them, if they have complication, if you test them, the markers are the same. D-dimer, elevated CRP. Those are the two that are very high when they have complication. So up to now, we don't have informed consent. and they're not going to do that because they don't want to look at the complication of vaccine. I 3 weeks ago, almost 3 weeks ago, I have a patient that died from the vaccine on the third booster. Okay, after 5 days, of getting the booster, was found dead in her bed. I put myocardial infarction, which is heart attack, and then thrombosis causing the heart attack. And what caused the thrombosis? Blood clots. What caused it is the vaccine. I put it in the death certificate, but I don't know if I'm gonna get in trouble with that. But I put it anyways, and so. So when people are getting vaccinated, number one, I tell people, my center I'm an accredited or certified vaccine center. I have all the vaccine. I have Moderna, I have Pfizer, J&J. I have the cocktail, okay? And we have a sign there, okay, vaccine available. But the problem is me. I know so much about the vaccine, what it can do, and the people that I'm treating. So when I talk to them, I cannot tell them informed consent. So I tell them stories. And so after they listen to my stories, they don't want to take the vaccine anymore. So I don't know if it's bad. I said, it's your personal decision. If you want it, I'll give it to you. But I have some cases like this. Because, there is none. If you look at the container of the vaccine, usually you have the drug and you have the leaflet, the information thingies on it. No, it's just a container and it has COVID-19 vaccine, Pfizer, Moderna, J&J, and then what it is. But no information, nothing that you can give to the patient up to now, okay? After I don't know how many millions, or we have already 1 billion, 4 billion vaccinated all over the world. And here in the US, we're up to 70% already. So it's up to you, but there are complications. I'm not saying everybody develops complication, but it's the occurrences is like you cannot close your eyes. You cannot put them under the rug or under the carpet because I treat them. Actually, they're more difficult sometimes. And the the ugliest one that I think they're doing is you just had the COVID and they want you to get vaccinated. What insanity is that? You just get the COVID, like 2 weeks ago. And the hospital is telling you, you have to get vaccinated. So what I started doing to the old people, I said, you don't need the vaccine. I'm going to write you because they are in an assisted living facility or independent living facility. And they go there and they vaccinate everybody. And so this little guy, he followed up with me after he got hospitalized for a week for the COVID. And he was fully vaccinated too. Fully vaccinated with Moderna, and then got the COVID, came to me for follow-up, and he said, Dr. Villa, I need my vaccine. I said, what the freaking vaccine? Because they are requiring them at the assisted living facility. I said, no, you don't. You want to get sick or what? No, that's why I want to get the vaccine. You see the mentality? I said, my dear, you do not need the vaccine. You already had the 2 vaccine and now you got vaccinated naturally. You had the COVID. At least he didn't have ADE because he didn't die. He survived, okay? It's one of those. So I had to write a letter. This patient had a full vaccination, 2 doses of Moderna. The antibody level is this. And now he just got infected with the virus again with the antibody this high. What he doesn't need, I put it there in capital letter, he doesn't need the COVID vaccine. So, well, if you want trouble and if you want to shoot yourself with another Russian roulette gun, then you do it.
All right.
But I'm pretty sure that if I gave him the vaccine, then he's gonna get sick. He's a cute little guy, and he has written, I don't know, 6 books since he retired. So I said, I don't want to destroy your brain.
Okay. The next question, Doc, is well, I think you kind of answered it, but the question is, do we still need IVM as prophylaxis even after getting COVID? Or maybe the supporting question to this would be, since you already have antibodies supposedly after getting COVID, how long will it take for you to take ivermectin again for prophylaxis?
You know, you can stop if you are somebody who's very strong. You can, if you are not going into the long hauler state, you can stop the ivermectin 3 months, 4 months, and then it depends on how high the infection rate in the community. You can take it as needed. You know, when you get exposed and uh, something like that. If you get exposed, you don't have to take it twice a week or something. So it's a common sense and a clinical decision that you have to make. But if the patient is going into long hauler state, then they're going to be taking it for the long hauler anyway. And at the same time, it becomes prophylaxis. So this is my protocol, and this is how I assess my patient. But the other doctors, you can disagree. Nobody is an expert on this disease. Nobody, okay? But I guess I have enough experience. It's like taking another fellowship all over again because it's been 2 years already. That's how long you do a fellowship to get a specialty in pulmonary, another 2 years in critical care, another 2 years in sleep, but you can all combine them and you can take a bargain or something. Instead of doing two, they might give you, I don't know, 3 or 4, but that's the way it is. To me, it's like a fellowship, learning this, this disease that's very unusual, you know.
Then
Okay.
the next question is,
So, Tata, hold on. Sorry, there's a follow-up connected to that ivermectin.
Mhm.
Doc, is the immunity lifelong? My understanding is the antibodies are temporary, but the memory cells remain, which means your body will still produce the antibodies when it's exposed to the COVID virus.
So you're talking about the vaccine or natural immunity or
Yeah.
both? Okay, let me explain that. When you get a natural infection, you're going to produce antibody. There's the acute antibody, which is called IgM for the COVID-2. And then that usually appears within a couple of weeks, you have the IgM. And then after 2 weeks, in the third week, then the IgG, which is the durable antibody, will also start to come in. The IgM can stay up to 4 months in the circulation. The IgG, that's the one that stays in the circulation between 6, 7, even up to 13 months. In some cases, they say it's 17 months. But the antibodies will disappear from the circulation. And it's true that even the antibodies are already gone, there's such a thing as memory cells. The B cells, the T cells, they memorize. So when the other infection, another COVID, whether it's the variant or the wild type comes in, your immune system is going to be very efficient. They will recall all those memory cells, the T cell, the B cell. The B cell is the one that's making the antibody. And once you recall that, it will produce the IgG that will kill the virus very quickly before it does injury or disease to you. So that is immunity, and it's a long lasting. The natural immunity, there's already some data that it can last up to 17 years. There are some scientists, they are claiming that it lasts forever. So, which is good. I mean, if you get exposed to different coronaviruses, it will be recalled all the time. And that's why some patients or some people, it's either their innate immunity is very strong, the first line, it will kill the virus right away. But some people, they have cross reactivity, cross protection. They had coronaviruses in the past, and then when they get infected with this virus, then somehow it also helps. Those cells will be recalled and produce antibody that will cross protect or cross-react. And so the patient got infected. The person who got infected with a COVID will not be very sick. And I think I have that, the cross-reaction, because I was exposed so many times and I kissed the COVID patient. No, it's my daughter. It's my loved one. It's my ex. No, I didn't kiss my ex. Okay. I just hugged him. And they all had COVID. I never got it. I thought I had, but I said, oh. And so I treated myself, ivermectin, IV vitamin C, and then I stuffed myself with all the vitamins. In 2 days, I was well. In 2 days, 3 days. Okay, let's get it 3 days. The first time I was exposed to that police woman, I really thought I had it because my assistant, my nurse, we were looking at each other. We had both sore throat. And then by the weekend, I was very sick. But I never turned positive. So I keep on breaking. I'm going to break my head thinking about that. So probably it's cross reactivity with the other coronaviruses. Plus, my immune system is very strong. You know, my daughter, I gave her everything. She only had symptom for 3 to 4 days. Yeah, they had a party, 5 teenagers, all got infected. So I let them stay in her house and then I treated them all at the same time, phone call. So, yeah. So
Okay
it's
na.
possible that like that. The vaccine, we already know the vaccine doesn't protect you from getting infected. The vaccine doesn't stop you from transmitting. The vaccine wanes, okay? It wanes because the antibody goes down in 6 months. That's why you have a booster. What does it give you memory? I don't know. Nobody knows. Somebody has to make a study on that. But we have the innate, our natural immunity, the natural infection. So I don't know. And that's why, when you have the vaccine, you also run I think the old people are getting sicker because number one, the vaccine, the antibody is waning. And number two, they have the ADE, the antibody dependent enhancement.
Okay. All right. So, okay na, Isay? Okay na. All right. So, let's go to the next one. Well, actually, this is a clarificatory question between, should it be sodium ascorbate or instead of ascorbic acid?
Yeah, the ascorbate.
Ascorbate, yeah. And then, what's your take on colloidal silver for nebulization with a ratio of 1:1 to distilled water?
It's okay. I don't use it that much, but I have patients using the silver,
Silver.
but I take it. Um, it's supposed to be antiviral and even antibacterial, but I don't use it as much. But when the patient asks me, can I use this, doc? I said, yeah, by all means, anything that will help you or protect you. And then, they believe on it. I have few patients using it as prophylaxis. And then as long as they're not getting infected, I'm not going to argue with that. Yeah, it's okay. As long you have to see how irritating it is if you're going to nebulize it. You can start just with a low concentration or, just like the hydrogen peroxide, they are using it in nebulization, both to kill the virus and to stop the coughing. So it's usually the concentration or the mixture is going to be 1 part or like let's say 1 cc of the hydrogen peroxide and then 2 cc of the normal saline. And I usually tell the patient just use half and see if it's going to irritate you. If you're not irritated, then do the full dose. So same thing with the colloidal silver. You can
Okay.
eat it and it's okay. Has to be food grade.
Oh, yeah. Would you suggest ozone IV for severe patients?
These people are on alternative. The ozone, yeah. My ex is the one using a lot of that ozone IV. And he injected on my neck. Yeah, if you have, by all means, yeah, it is supposed to be But again, I don't use it in my office. So if the patient wants ozone treatment, hydrogen peroxide IV, I send them to the on the other side of the highway. That's where my ex practices, and so he does all that. It's alternative treatment. If you want to use it, just make sure that the doctor who is using it is really familiar with how it works. Okay, I don't want you getting uh, air embolism or anything like that. Okay.
Another question. Do you have a standard protocol you follow, or does it differ per patient? Are there standard labs required before prescribing?
The standard protocol, the recommendation that I follow in the beginning, when there was no recommendation yet, I used to just give all the immune booster. I do IV vitamin C, I do NAC, I do the B vitamins, and then I give that to the patient as an immune booster and all the vitamin D, high dose vitamin D. And then and quercetin. I've been using that already, even before the ivermectin and hydrochloroquine, because that was the only thing I could use, immune boosting, combination. But when I became a member of the FLCC, so basically I kind of combine the the protocol, the IMASK, the Math Plus. The IMASK is a recommendation, but I usually adjust the doses. Some of the doses that they use is like it's like baby doses with what I'm using. But again, you have to be comfortable with using these different agents. My background in functional medicine and nutrition, gives me that level of comfort. And that's why when I say high dose, I use the high dose when I can see if the patient is high risk, when the patient is older, when the patient is likely to develop a severe disease. I don't, hesitate to throw in, including the zinc, so that the patient doesn't get sick, you know. And so the eye mask, go there. That's a very good, it's a very good place to start. You do the eye mask protocol prophylaxis, and then you can go up and down with the dosing. You just have to know when to go up, when to go down, and what are the interaction of everything. Okay.
Yes. Okay. Another question. I had COVID 7 months ago, and until now, my sense of taste and smell is still 0%. What kind of medication or supplementation should I take for me to fully recover? I have been taking vitamin C, vitamin D, quercetin. Yeah.
So you didn't take the ivermectin? There are
Um,
already
it's
reports that
it's heat
require that.
ivermectin, virgin coconut oil, Covey spray. Oh no, wait, Covey spray. It's so hard to open it. Wait. Okay. Difflam spray and doing steam inhalation and gargling warm water with salt every single day, but to no avail. He's starting to lose hope. Yeah.
So did she use ivermectin?
Yes, po. Yes.
Do another round. Do another round, like acute. You have to do another round.
Okay. And then
And you should also do some training of your smell and taste. Like every day you should start smelling different scent. You have to retrain.
oh,
You have to retrain. You can even search. I don't know. There are some, protocol on how to retrain your smell and your taste. Um, because that's 6 months. That's not very unusual. But if I were you, I would do another round of ivermectin as if you have acute COVID, and even a little bit of corticosteroid, probably just a low dose of either dexamethasone or methylprednisolone, just the lower dose. Ask one of the doctors to give you a prescription. But I would do another course of ivermectin. Yeah, and I won't stop it until I can see that there is improvement. Okay.
From the same person, my brother got his first vaccine and started to shed. He infected my uncle's 60 years old diabetic hypertensive and grandma who is 86-year-old stroke patient in the process. By God's grace, they both survived. After learning his lesson by not believing in me regarding the effect of the vaccine, should he still finish his second dose?
Well, he didn't have side effects, right?
I don't think so.
No. So then, I mean, it's his decision, no? But a lot of times the complication, what do you call this? The complication from the vaccine usually happens after the second dose when the immune system is already primed. And then chances are that's when, if he's a young male, you better be careful with the myocarditis and pericarditis because it usually happen on the second dose. And if you're going to take the second dose, yeah, you need to take anticoagulation, like even with aspirin alone, or you can actually take ivermectin on the day of, or but the day before the jab, you start taking ivermectin and you should take it for 7 days. I usually treat the vaccination like acute COVID because if you look at it, it's like the, the spike protein is the one that is pathogenic, right? That's the one that will cause the disease. It's not the viral particle, but the vaccine, if you look at it and if you understood my pathophysiology, there is no viral state. It goes into the immune states because you have the viral debris or the spike protein that will come out. So it will go through the same process of immune response, maybe not as bad as the cytokine storm that you see in acute COVID, but it will go through the same thing. So if you get complication from the vaccine, that's what is happening, the inflammation in a mini cytokine storm. But in some patients, they are unlucky, they die from it because, because of the blood clot, right? The blood clot. If it happens in the brain, stroke. If it happens in the heart, that's a heart attack. If it happens in the lungs, then you have pulmonary infarction. So if it is big enough or a lot, then in the heart, all you need is one clot in one of the major arteries, then two things can happen. You know, your heart, especially in your sleep, it can go into an irregular heartbeat, a malignant heartbeat, so, ventricular tachycardia, fibrillation. You're not going to wake up from that. You understand? It's the blood clot that will kill people like this. Okay.
So, for the post acute prolonged symptoms, what can we do with brain fog or what effective supplements would you recommend us to take?
Okay, you have to go just the same on the IMAS, the vitamin D, C, D, and then you have to take high dose melatonin and you have to get fluvoxamine.
Who's
You have to,
dog is that? Okay, wait. Mike. There.
as a little puppy. Okay, so you have to, what did I say? You have to take fluvoxamine and you can also try the fluoxetine. You know, because the fluvoxamine can go into the brain and stop the inflammation by suppressing the alpha receptors, we call that. And you have to try that. You can probably try it like for a month, and if it's going to make a difference, like within the 14 days, you should see some improvement. You know, take some melatonin and then also the IV vitamin C. But we're using the alpha one, the alpha receptor blockers, fluvoxamine and fluoxetine. But I prefer the fluvoxamine. Might make you sleepy, but that's the intervention for foggy brain.
Okay. Now, some studies in Australia say eating veggies and fish with omega fatty acids give you protection from COVID. What about in the US?
Yeah, we use the fish oil, the omega-3, the what do you call yeah, the fish oil. We use high doses of that. It's part of the hospital protocol. You actually have to give the patient like 4 grams in a day. So that means it comes in like 1 gram each. So you have to give the patient 4 capsule of those. Yeah, we do use that in high doses. That's also a natural blood thinner, the fish oil. So that protects. Vitamin E is another blood thinner. Um, the other anti-inflammatory that we also encourage people to take is the turmeric, the curcumin. Yeah, that's another one. But you have to take it with the black pepper because it acts much better when it's in combination with the black pepper. Or the other thing that I didn't mention there, I forgot, but I've been using also L-arginine. It's like that because I recycled my my slides. L-arginine is an amino acid. Basically, what it does is it produces nitric oxide, and nitric oxide, NO, it helps the inflammation in the endothelial cells. What is that? Endothelial cells, that's the skin of your blood vessel, and that's where all the the problems begin, because inflammation and then injury to the endothelial cells will create more inflammation. It will also attract the all the blood components to form a clot, whether it's a white clot or a red clot. So if you have enough nitric oxide antioxidant in your blood vessel, in the vascular bed, chances are the effect of the cytokine storm is not going to be as bad. So you guys have to, even the vaccinated one, because the blood clot is the most common, side effects. No, most common side effects is fatigue and neurologic, impairment. But the blood clot is the third one. So you have to take L-arginine, 1,000 milligrams, once a day, 2 times a day, 3 times a day. Because if you look at COVID, really, it's an infection, it's an inflammation, but actually it's at the level of the vascular tissue that the damage or the injury happens. So it eventually becomes a vascular disease, but even the lungs, when it is going through all that inflammation, actually the little blood vessel are the one damaged. That's where you have the blood clots, the microcirculation. You have blood clots. So when you take a picture, you don't see the big blood clot because it's in the microcirculation. And that's where all the inflammation is happening. Okay.
Okay.
I know it's a lot of information, but that's the way it is.
If one has had heart failure and has contracted COVID, is ivermectin still advisable?
Yes, the more that you should use it, because the COVID will affect your heart muscle. Even if you don't get the heart attack, even if you don't get a blood clot, it weakens the myocardium or the myocytes, the heart muscle. You have to remember, there is a mitochondrial dysfunction. Remember, I was discussing it earlier. The heart muscle, it has a lot of mitochondria. They have a lot of little mitochondria, the powerhouse, and it needs that because the muscle or the heart is pumping all the time. It's not like your regular muscle. The heart is pumping all the time. That's like in perpetual activity or physical activity. So it has a lot of those powerhouses. And just imagine if they're affected by the COVID in one way or another, then you're going to have a very weak heart. So those people, that's why they are very high risk when people are already having congestive heart failure and have previous heart attack. they don't do very well with the COVID because it weakens the heart even more, and it will just stop. That's how they died. And then no oxygen, then it will just stop. That's it.
Oh, okay. If someone is taking ivermectin as prophylaxis and gets exposed to someone with COVID, should prescription be revised to allow for 3 days of increased dosage to counter the exposure?
Yeah, usually that's how you do it. When the recommendation of FLCC is day 1 and day 3, but I do it 3 days in a row. 3 days in a row, because just because I treat a lot of this delta, it's very fast. So you have to hit it like also fast and a slightly higher dose. So they would take it. I would ask them, take it 3 days in a row. And if you become symptomatic, third, fourth day, double the dose, come here, let you get tested. I give monoclonal very fast. Boom, boom, boom. Okay. So you double the dose on the third or fourth day when the patient is starting. Okay, I'm starting to have sore throat. So instead of taking it one a day, you take it twice a day, 5 days, and then call. I tell them when I see the patient for wellness checkup for COVID, first, I identify them as high risk or low risk. And then I tell them, okay, you're going to take prophylaxis for ivermectin on all the nutraceutical, and then you are also qualified for the monoclonal antibody infusion. So I make them aware whether they're qualified or not, because, and then I tell them, because I talk to people from all over the US. So after we hung up, you will make a call and find out where the infusion is, so that when you get infected, because the ivermectin can either, number one, completely protect you, or it's gonna, you're gonna get infected, and hopefully the disease is not that bad. So don't take chances because you are high risk. Make a phone call, and then uh, enroll yourself for monoclonal infusion. And then they call me and I give them some more, whatever, all the other medication. Those ICU or hospital agents, drugs that you use, nobody will stop you from using them in the outpatient if the patient is getting bad. Okay? Use all your guns to kill the enemy.
Do you have any preference between aspirin and Clopidogrel?
Uh, the aspirin first, the clopidogrel, you can use that in higher risk patient, but a lot of times the high risk patient are already on it, so by default they're already anticoagulated. But if it's like somebody like not with a lot of comorbidities, the aspirin first. It's not a matter of preference, but which one does the patient need, or which one is suited for the patient. Sometimes you can even use them together,
Okay.
but you have to make sure that the patient is not going to develop GI bleed from the irritation of full dose aspirin. Okay.
For someone with G6PD deficient, is the protocol the same for stage 1 to 5 or 6?
Probably, the question is the G6PD is, you have to be careful with vitamin C. If you have a G6PD deficiency, high dose vitamin C may cause hemolysis. Hemolysis, the red blood cells, they will burst. And so you're going to end up having a very sick patient. So that's what you have to be careful with the G6PD deficient people. They're usually anemic. The G6PD is, I think it is more common in men. And so when you see somebody who is anemic, a male, you have to screen them. But I don't think Filipinos are, or we are not susceptible to having that genetically. And so, but you just have to be careful, okay, because it can happen. So when it comes to use of ivermectin or other medication, that the ivermectin is not contraindicated in G6PD deficiency, because an enzyme. And by the way, the ivermectin also has a blood thinning effect by way of inhibiting the C147 receptor in the red blood cells. When the virus attaches to that receptor, the red blood cells, they stick together and form a red clot. Okay? So when you have the ivermectin, the virus cannot stick to your C147 receptor, and so it prevents the clotting. But sometimes, a lot of times, you need another anticoagulant just because there are other ways that you can form clots. The platelet can also stick together and they can form clots, white clot. And then, when the cytokine storm is very strong, then you are liable to form blood clots. So you have to give other anticoagulants to prevent the thrombosis or blood clots. Okay.
All right. Someone says, Doc, in Medscape, the drug-to-drug interactions between ivermectin and quercetin shows quercetin lessens the effect of ivermectin.
Yeah. So that means that it lessens it's not that it lessens the effect, but the level of the drug goes down. Remember, I was telling you earlier, I think that they compete in how it gets metabolized in the liver. What we call cytochrome 450, P450. So usually the ivermectin is preferentially metabolized, but it looks like in quercetin, especially in high doses, may suppress, or actually the quercetin gets metabolized and then the ivermectin is not utilized properly. No, it's the other way around. It's the ivermectin is metabolized more, actually. So in that respect, then the effect is less. So you have to lower your quercetin if that's the case.
What is the, I don't know if this is a typo, what is the MX zinc our body needs? Maybe it's milligram? I don't know.
Oh, how many milligrams? If just for prophylaxis, don't go any higher than 30 or 40, because as I said, when you are taking high doses of zinc, you are liable to develop like copper deficiency. Okay, so it's actually good. You can also throw in the zinc that I use is already in combination with the copper, only in low doses. Okay.
Okay. Would you recommend the use of IV glutathione?
Yeah, that's I use that. I use IV glutathione or NAC. The NAC and glutathione are kind of mother-daughter. The NAC is the mother molecule, and then if you metabolize it, it becomes glutathione. But both are antioxidant. Yes, I use glutathione. If the patient is very sick, I throw in everything. Yep.
Can melatonin be taken by breastfeeding mothers?
Yeah, it can. I give it unless I don't, I'm not aware that it's being, excreted in the milk that much. Probably it's going to be just a little bit. But if the baby start going very, very sleepy, then the baby is getting it. It's not dangerous to the baby. It's not really big amount. If it's going to be excreted in the milk, it's not going to be so much. Okay.
Then please comment on the use of antibiotics as part of standard treatment, because here in the Philippines we have doxycycline and azithromycin.
What's the question? Which one?
I think she's trying to ask, yeah, what's your take on using doxycycline and azithromycin here in the Philippines?
Okay. We use those agents, the antibiotic, not as a prophylaxis for secondary infection. Okay, we use that because we know that they have some COVID activities and some anti-inflammatory. So in the earlier study in the use of ivermectin, it looks like the ivermectin works very good with either azithromycin or doxycycline. It's a matter of preference, whichever one gives the patient less side effects, because the ivermectin, in the first time you use it, sometimes it will give you diarrhea and then it goes away. And then the azithromycin can also give you diarrhea. But the doxycycline sometimes has more side effects in terms of, they're getting dizzy and also GI upset. So see what the patient will tolerate, but we are not using it to treat another infection, okay? A lot of times the COVID, they really don't have another bacterial infection unless they become very sick and the immune system really goes down, and then they can have a secondary infection, especially those people who have existing chronic lung disease. But otherwise, the pneumonia that you get from COVID is not bacterial pneumonia. And the tendency of doctors over there, they're just giving it, for the pneumonia. But the pneumonia is a COVID pneumonia. It's an inflammatory pneumonia, not a bacterial pneumonia. But I'm not saying that you cannot get bacterial pneumonia. And that's why I think somebody asked, do you want to or do you need to take a baseline blood test? Yes, I do. But in the Philippines, I'm treating people there and they're not excited about getting initial blood tests. I guess it's because of the expense. But when I see people here, they come in and then they have COVID, they're COVID positive, they have symptoms. I do the baseline CBC Chem 12, the CRP, the D-dimer, the ferritin, and the troponin. It's like a baseline. So that's where you base it. When the patient is admitted in the ICU, we do it daily, every day. Like it's a standard order, daily. I mean, because we can see when the patient is, responding to the treatment. When they're responding, the markers go down. That is, the cytokine storm, goes down, and especially the D-dimer, you have to be aggressive with that, because the higher it is, the higher the chances of you forming blood clots. Okay.
Okay.
Uh,
I think we should have, I'm sorry, I know a lot of you posted questions, but I think we should cut it to the last two, Doc, because it's really
okay.
been such a long time.
There's one question here. Ivermectin has synergistic effect with molnupiravir. Okay, let me just tell you about this new Merck medication. The way it works is it stops the viral replication, and the way it works is through it's called the nucleoside. It inserts into the viral genome. So the virus is like a genetic information, right? So this medication will insert itself into that, and then what's going to happen? The virus mutates to its demise, meaning it mutates and it cannot replicate anymore. And so that's how it kills the virus. It stops the virus. But the problem is, when we have certain types of chemotherapy, and it's the same mechanism. When you put it into the body of the organism, the human host, it will mutate the cell, let's say the cancer cell. But the thing is, it's the same mechanism. It can infect, or it can also go into our normal cells and insert itself into the genome. And so there's a chance that it can hurt us by mutation as well. It's a little bit scary. And so it targets the actively replicating cells, the virus that's replicating. So it may affect cells in our body that are actively replicated, and it can damage them. How? Like, let's say hair, it always replicates, it's actively replicating. So you can end up being calbo because your hair is going to fall. So in the gastrointestinal tract, I don't know, we have to see, but I think they have almost almost the same mechanism how it works. But I my tendency is not to use them together, because if something happens to the patient, you won't know which one gave what. And so it's not out yet, but they already announced it that it's going to be out. And it's $700 for treatment, okay? $700 for the 5-day treatment. It only reduces the risk by 50%, relative risk. And ivermectin is between what, 64 to 82%. The monoclonal antibody is 92. So, okay,
Uh,
but it's much more expensive.
oh,
Okay, whatever.
last, excuse me. Last question, Doc, for the night, and then maybe we can have a take two, or we can just send you the questions and you can have another round next time. The last question is 54-year-old male with HIV 450CD4 count stage 2, takes Ritacom and Zydolam, moderate COVID symptoms. Can ivermectin be given?
Yes, yes, do it. Do it and give that patient like vitamin D, higher dose of vitamin D. I would do it. This is the kind of patient that HIV is a very good candidate for monoclonal antibody, monoclonal infusion, that kind of patient. Probably they can also use if they advance, because the leronlimab, the other one, the Maravirac, they are all anti-HIV. You know, the CCR5 inhibitors, probably those HIV patients would be able to benefit from that, from those agents as well. It's available in the baricitinib, no, the leronlimab is available in the Philippines. If that patient, goes down and all, you should reach out to the people who can give you the leronlimab. And then there's just one interesting question here. The G6PD and vitamin C, what's the cutoff? Yeah, when you're already reaching like a 25 grams or 25,000 milligrams, you really have to be very careful. And it's also the prolonged exposure. You can have hemolysis on a person with G6PD deficiency. Okay, so you have to be very careful.
Yes.
Okay.
Oh,
Still so many questions. Still so many questions.
You should just have like a thing like this. I'm not gonna lecture. I'll just answer a question, because all of you will benefit.
Yes, Doc. Let's have a
Yes.
take
Everyone's
two
gonna be
for that.
clapping.
Yeah.
Yes. Okay. So, I guess we have to close it up. Again, thank you, Doc Villa, and everyone who joined us this evening. Stay healthy. Don't forget, COVID is survivable with early treatment. Please, early treatment. Let's keep hope alive by sharing what we learned tonight. Thank you very much and good evening.
Thank you very much,
Thank you,
Dr. Villa.
everyone.
Thank you,
Dr.
everyone.
Villa.
Thank
Thank
you.
you so much,
Okay.
Doc.
Dr.
God bless you.
Marivic, praying
Who-
for you.
Who's
Remember,
that? Who's that?
Rosanna.
It's Rosanna.
Remember I told you the other time, every time when I saw you cry,
Ah,
Thank you for good night.
she's always reminding me that I cried. I lost it.
no,
I
but
tried, I
but
try
that's
not
really,
to do it again.
yeah, but you really have to, we really have to pray for them. And that's why I'm
Yeah.
praying for your advocacy.
Yeah, I know.
Yeah.
I know. But sometimes it gets you because there's just so many, and you also get tired, and you go to sleep thinking about it, and then you wake up,
Yeah.
you still think about it. It consumes you. So it's like, okay, let me take 10 milligrams of melatonin. Then you
Yeah.
yeah, yeah.
Okay.
So,
Basta you're in our prayers.
Yeah.
You are
thank-
always in our prayers.
Someone suggested like Dr. Mobin's chit chat. Doc, are you familiar with that?
Dr. Rubin.
Oh,
We,
Dr.
we can do
Mobin?
Dr. Mubin's chit chat style. I'm not sure.
Oh, Dr. Mubin. Yeah, he's like,
He
I
has a
can,
chit chat style version of.
yeah, that's okay. But you more on the clinical side. Dr. Mobin is very theoretical, but which is also good. What I impart to you is my
It's
actual
very
experience in
Yes.
treating patients. So,
Mhm.
I mean, I don't know if Dr. Bean is actually treating actual cases. Probably he does, but I don't know. It's not the same. I just, yeah, you learn also, you actually reconcile and confirm what the theorists are telling you. And then when you
Mhm.
see them in the actual cases, you can tell, no, it's not quite like that. It's like this, because you can see the patient, how they respond, how they present, and how they behave. No?
Yeah.
Doctora,
Yeah.
so can I ask you one question? Personal question.
Tita.
It's my
Ano,
problem.
hirit siya, hirit. Okay.
Hirit ako, doktora. Kasi,
Okay, hirit.
okay, my daughter lives alone in a condo. She rides the elevator several times a day. Now she's telling, Ma, I'm scared to visit. She comes to visit me once a week. She's scared to come down because she might bring the virus to me. But we are taking the supplements every day and ivermectin twice a week. Is there any other measure that we should take?
No, that is, you're actually, if you're taking the ivermectin twice a week and she's taking it too, she should take it before she goes to you. Then that should be okay.
Yeah, because
You,
our schedule
you
is
know,
Tuesday and
you,
Saturday.
yeah,
So,
because you cannot also that's a lot of fear and a lot. I know you want to take precaution, but you have a life. You have to live your life as well, because it's affecting us psychologically already. It's getting to the point that it's paralyzing people, and usually it's the fear that paralyzes you. You take all the precaution, and you're already taking prophylaxis. Then live your life a little bit, because if you're happy, it makes your immune
your
system get
system,
stronger.
yeah, stronger. Yeah. Thank you. God bless you.
To those who are still here and listening, right, you may want to message us through the Facebook if you have questions, so that next time we have a huddle with Dr. Villa, she'll be prepared to answer your questions. Right?
Yes.
Yeah.
And volunteer if you can.
Yeah. Yes.
Please.
Yes,
Ano na
please.
lang, yeah, question format, so that it's most of the question, you guys don't question the theory, but it's more on the, how you use medication, how to avoid, so
Yes.
things like that.
Actual
I just
cases.
hope, yeah,
Yes.
I hope the doctors, got something from this, because I really would like to, for the doctors to get more involved. That's the only way that we can really help a lot more people. And it's also very good that, there are concerned citizens like you who are getting together and making efforts to help the sick ones. So
Yeah.
I applaud you. Okay.
Thank you.
Thank
We
you.
applaud
We
you too.
applaud you too.
We applaud you.
Oh,
Yeah.
Applaud you too.
yes.
Thank
Okay.
you. Thank you,
Okay.
G, for your Zoom.
Mm-mm.
And
Thank
thank you,
you.
Welcome.
Doctora, again.
Thank you,
Yeah.
Doctora.
Thank you very
Thank you,
much.
Doc.
Good
Good
night.
night
Bless
from our end. Good
Bye.
night.
everyone. Bye-bye.
Please
Bye.
message us a
Like
Good
Facebook
this.
night,
page
Who's
now.
everyone.
doing this?
Morning,
Like that.
Doctora.
Who's doing that? When you say something, who's doing that?
Yeah.
Somebody is doing that when you say, but I
Beauty
think it's the
queens. Beauty
yeah, the
Oh,
queen.
queen.
Beauty queen. Say
Oh my
bye-bye that way.
God. Hi.
okay.
Oh, really? So then I'll do it this way. Hi. Hi.
Okay, and the
Bye.
meeting in three,
Good
Okay.
two,
night.
Good
one.
night.
Good
Bye.
night,
Good night. Good
everyone.
night.
Night.
Hi.
Yes.